So good afternoon and welcome to today's bill hearings for the House Health and Government Operations Committee. I'm Jocelyn Pena-Milnick and I'm here with my chairman, Pendergrass, and the rest of the committee. This is a virtual committee meeting, so I ask for your patience if we encounter any technological or streaming issues. This bill hearing is being streamed on the Maryland General Assembly's YouTube channel. Remember, even though we're meeting on Zoom, please adhere to our usual committee rules of one question and one answer for the panel, not one question and one answer from each individual panelist. Also, please keep your questions shorter than the expected answer. We have a lot of bill hearings and about 50 witnesses today. The bill sponsor or a designee is allotted 5 minutes to present the bill. 5 witnesses will each be allowed to speak for 2 minutes in support. Please stay in the hearing until the delegates have had an opportunity to ask questions. Next, 5 witnesses will each be allowed to speak for 2 minutes in opposition and then respond to questions. Please conclude your remarks when you see the timer that is finished, and Richard does an amazing job and he'll let you know. Members, you must refrain present with your video camera. Those are the rules on during the entirety of the hearing. Thank you so much for coming today. We appreciate it. The bill order for today is House Bill 245, followed by House Bill 80, House Bill 6, House Bill 534, House Bill 353, House Bill 430, and then we'll end with House Bill 275. In addition, if you were not able to get that, Richard keeps it in the chat room and you can follow. We're going to start with House Bill 245, Delegate Resnick, and the title of the bill is Program for Preventing HIV Infection for Rape Victims, Alterations, and Repeal of Sunset. We are joined by the judiciary, Delegates Shetty, Munoz, and Bartlett. Welcome, Delegate Shetty, Munoz, and Bartlett to our committee. Delegate Resnick, will you be so kind and get started?
Thank you, Madam Chair. Really
Our
appreciate
pleasure.
the opportunity to be here with all of you today. Thank you to the members of HGO and obviously the members of Judiciary who are joining us as well. This bill, as introduced by the Chair, HB 245, is a bill that would make permanent a pilot program we actually passed about 3 years ago. In 2019, we created a pilot program that would test the feasibility of providing rape victims with NPEP, a prophylactic drug that prevents HIV infection. I'm pleased to announce that the program has been a great success. Over the course of the first 2 years of the program, 328 people have received NPEP as part of the pilot program. That's 328 people who, without this pilot program, could have potentially contracted HIV as a result of a rape they experienced and would be forced to live with a constant reminder of that terrible event. While NPEP cannot reverse a tragic rape, it can help to save a life and prevent the continued spread of HIV. If the human costs are significant, the financial benefits are equally astounding. The lifetime treatment cost of HIV medication is estimated by the CDC at $380,000 in 2010 numbers. Adjusted for inflation, we're talking about $500,000 lifetime per individual. If, and obviously this is an overestimate because we can't possibly know how many people would have contracted HIV, but if all 328 people who have received this medication over the last 2 years contracted HIV, that would be a cost of $150 million. The program prevented this, and the cost for a cost of just around $500,000 over the course of 2 years, which is a much lower estimate, thankfully, than what we authorized the original pilot program for, which was $750,000 per year. So we even saved money there. The financial benefits of the program are better than they appear at first glance. The money itself is actually all special funds. It does not come out of the general fund. It is generated by the Criminal Injuries Compensation Fund, which are fees that are assessed at the circuit and district courts. This program has been a tremendous success, and I ask the committee to continue its good work by lifting the sunset and making this pilot program permanent. I would like to thank you for your time and ask for a favorable report. Of course, I'm open to questions on the bill.
Thank you, Delegate. Next, we have Ms. Jane Crinkett from the Maryland Hospital Association. Good afternoon.
Good afternoon. Thank you so much, Chairman Pendergrass and Vice Chair Peña-Melnick. My name is Jane Krinke. I'm here today on behalf of the Maryland Hospital Association's 60-member hospitals and health systems in support of House Bill 245. Hospital-based sexual assault forensic medical programs across the state deliver trauma-informed care to survivors of sexual assault, and state law ensures they don't incur any out-of-pocket expense. As Delegate Resnick spoke to prior to 2019, reimbursement for the full treatment of HIV prophylaxis was not covered. And since then, this program has helped open the doors for patients to access that treatment. So hospitals strongly support House Bill 245, which would make this program permanent. We've worked closely with our partners at the Maryland Coalition Against Sexual Assault, who's really the leader behind this bill and issue, and closely with the Sexual Assault Reimbursement Unit to streamline the process and the forms throughout the pilot program. And we've seen those successes. Dr. Pamela Holtzinger, a registered nurse and forensic nurse examiner, wasn't able to be here today, but she wanted to make sure that I shared how important this program is to her patients. Often they come with grave concerns about contracting HIV, and this has provided an option that they've expressed a lot of gratitude for. And for those reasons, I'd ask a favorable report on House Bill 245. Thank you.
Thank you for being with us today and for your testimony. We do not have Ms. Ann Winkler, but we do have Ms. Jordan from MCASA. Good afternoon, Ms. Jordan.
Good afternoon, Madam Vice Chair, Madam Chair, members of the House Government Operations Committee, and guests from the House Judiciary Committee. I'm Lisa Jordan with the Maryland Coalition Against Sexual Assault, here in strong support of House Bill 245. Thank you to Delegate Resnick and really to all of you for your continued support of sexual assault survivors. The Maryland Coalition Against Sexual Assault is the coalition of all of the rape crisis centers across the state of Maryland. We are the people who help your constituents when they suffer a sexual assault or a rape. Many of these survivors seek medical attention, and as has already been ably described by both the sponsor and my colleague, Ms. Krinicki, one of the things that people seek medical attention for, is this fear of HIV. In fact, 72.6% of rape survivors report extreme fear or concern about contracting HIV, and almost 92% express that they are fearful of this. This program is genuinely a success, not only because it has reduced HIV and it has reduced financial burden, but it also reduces the emotional burden on these survivors. I won't repeat what my colleagues have already testified to, but I do want to please encourage you to report favorably on House Bill 245. It is one of the things that you can actually do to help rape survivors in the aftermath of a very terrible and traumatic event. So with those comments, we ask for a favorable report on House Bill 245.
Thank you so much for your testimony today. We actually do not have any other witnesses, so we're going to open it up for questions. Our colleagues in Judiciary, you're welcome to ask questions as well. Are there any questions? Delegate Bartlett? How are you?
I'm doing great. How are you doing, Madam Chair?
Doing well. Thank you for being with us.
I have a quick question for Lisa Jordan. Thank you for being here. I'm going to ask you the same question I asked when the pilot bill was, when we had the hearing for the pilot bill. And that question is, how young are some of the individuals who may benefit from this program?
Yeah, these drugs are available for children, and I'm not sure, I don't know, and I will get you that information, the exact date, but I believe it's about 2 years old. So it's a medical determination about when those drugs are safe. But you're absolutely correct to point out that this is not just for adult survivors, it's also for our youngest survivors.
Thank you very much, Delegate, for your question. Are there any other questions for this panel? Seeing none, thank you. You know, you forget the bills that you pass, and under our leadership of our chairman, this is something to be proud of. You know, it actually works and it's doing great things. Thank you so much for being with us today. And since there are no other questions or concerns, this concludes the bill hearing on House Bill 245. Thank you, Delegate, for being with us today.
Thank you.
Our pleasure. Next, we have House Bill 80, Delegate Collison and Delegate McKay. And it's actually,
Madam Vice Chair, no, that's on the next bill.
oh, I'm so sorry. That was,
That's okay.
okay, sorry about that.
That's quite all right.
Delegate McKay, we were gonna give you work. This is what
Yeah.
you get when you come to HGO, we work. So we have House Bill 80, Delegate Collison, Home and Community-Based Services Waiver Participation in Applications. Go ahead, Delegate.
Thank you very much,
Our
Madam
pleasure.
Vice Chair, Chairman Pendergrass, and members of the committee for the opportunity to present House Bill 80 to you. This bill seeks to provide more opportunities for our most vulnerable residents to age in place by getting appropriate medical services in their homes and community. It does this by making several requirements on the Maryland Department of Health. It asks them to make a request to the Federal Centers for Medicare and Medicaid Services to increase the current cap on Medicaid waiver slots for these in-home services to 7,500. It asks them to develop a strategic plan for filling all the waiver slots. And it asks them to double the number of people on the waiting list who are contacted each month from 300 to 600. You have two amendments before you, one that requires the department to work with the community-based partners in the outreach and follow-up processes. And the second one moves up the implementation date to July 2022. Our residents should not have to wait any longer. This is the third time that I've brought the bill to you. And I believe that there were others before me who were asking to make all the waiver slots we have available from the federal government to accessible to those who need them here in Maryland. The ultimate goal would be to eliminate the waiting list or registry and make sure that those who are eligible are getting the services they need in an environment that is most conducive to meeting those needs and maintaining their quality of life. Unfortunately, I have to report to you that while the department understands these needs, there has been no significant progress in filling the slots. And in fact, the waiting list has stayed steady at 21,000 of the latest report, and only 4,286, which is down about 300 from last year, of the slots that we are allotted are being used, which is about 2,100 less slots than we have. I met with the secretary and members of his staff in November. They explained to me that they had been sending out 300 applications a month and that they get an average of about 30% response each month. They reported that they follow up with phone calls, but the number of slots are still declined. That has not increased. The pandemic made placement in institutions more challenging over the last 2 years. So it seems like focusing efforts on enabling those who could stay in their homes to stay in their homes. It should be noted that the slots that are still available might actually meet the needs of the people who are eligible on the waiting list. I met with members of the board of the coordinating centers, which is one of the community-based organizations that MDH partners with. They helped me to understand how successful outreach to these vulnerable populations cannot be achieved through letters and phone calls. They may not understand the documents. They move from family member to family member. They may feel disenfranchised by the system. That's why I'm asking that they partner with these community-based services to address that. And there's a great difference between the fiscal note prepared by DLS and the letter that you have from MDH regarding the cost of this program. I have speakers later in the panel who are going to address it directly, but I wish that MDH was here to explain how they did their numbers. And over the 3 years that I have done the bill, the cost in the fiscal note has gone from $22.6 million to 1.5. And I really think that that's because we have a better understanding of how many individuals would actually qualify for the cost of home care services as they compare the cost to nursing homes. We have better information now. It's time to make progress. As a state, we should be committed to a continuum of options for people of all ages and disabilities to meet their needs for a reasonable quality of life. The state should be spending the money and will actually save money on the individuals that are not placed in institutional settings, but are rather receiving the services in their home. With that, I ask for your favorable opinion and thank you very much for your attention. I will turn it over to my panel, Madam Vice Chair.
Thank you, Delegate Collison, for your testimony. Our next witness is Ms. Lauren Burns. Good afternoon, Ms. Burns.
Hello. My name is Lauren Burns, and I'm here as a member of the Maryland Occupational Therapy Association to express my support of House Bill 80. I've seen how the waitlist process for home and community-based services is a current challenge for both clients, family members, and the professionals who support them at the local and state level through my experiences with an organization that serves older adults. For example, I've heard of an individual who was mailed a letter from the state to confirm their waitlist status for home and community-based services. And the individual had not been regularly checking their mail and therefore missed a deadline to confirm that they wished to remain on the waitlist. This caused great distress for the individual and their loved ones as they had to start the waitlist process over and basically reapply. House Bill 80 will allow state and local partners to collaborate to increase access to home and community-based supports to the Marylanders who need these essential services most. Aging in place is proven to permit individuals to have a high quality life and engage in more choice and options about how they would like to live and spend their time. So thank you everyone for hearing my testimony today.
Thank you for being with us today. We appreciate it. Next, we have Ms. Teresa Titus Howard. Good afternoon, ma'am.
Thank you, Madam Vice Chair. My name is Teresa Titus Howard. I'm the President and CEO of the Coordinating Center, and it's my pleasure to speak to you today on behalf of Ivis Burris, a Community Options Waiver participant in favor of House Bill 80. As stated by Ivis recently, I thought my life as I knew it was over, but thanks to the Community Options Waiver Program, I was able to get a second chance at life. Ivis was born and raised in Baltimore City. In 2013, Ivis was hospitalized and required intensive medical care because of a collapsed lung and a diagnosis of muscular dystrophy. Ivis spent the next 3 years in the battle for her life. Refusing to enroll in hospice, Ivis's family remained optimistic and chose to keep her on life support at the long-term nursing facility. After 3 long years on life support and months of intensive rehab services, Ivis defied all odds. Determined to return to her community and not to be a burden to her family, Ivis was determined to find affordable in-home supports. She applied for the Community Options Waiver Program while she was in the nursing home, but did not receive it before she was discharged home with only minimal services. She waited 4 years without the Community Options Waiver Program until she happened to run into someone on the bus who volunteered to help people enroll in the waiver who were eligible. Thankfully, soon after, Ivis was selected from the waiver registry and was connected with a nonprofit that helped her enroll in the Community Options Waiver Program. Today, Ivis and her son, a young adult with Down syndrome and muscular dystrophy, are thriving with the care of their care team provided by the waiver. Ivis says, the team is amazing, never letting me give up. Even my most lowest moment when I wasn't strong enough, my family and my coordinator continued to push me. Because of that, I decided I wanted to turn my misfortune into fortune for other people. Ivis is now an advocate, educating others about the Community Options Waiver Program and supporting their transition back to the community. In conclusion, she stated to me, it seems like the waitlist issues are just getting worse. I know of multiple people who have died waiting on the Community Options Waiver Program. At this, I ask for your support for House Bill 80. Thank you.
Thank you so much for sharing her story with us. We really appreciate it. Next, we have Ms. Susie Murphy.
Good afternoon, Vice Chair. Thank you. And thank you, committee members. My name is Susie Elder Murphy. I'm the owner of Deborah Levy Elder Care Associates, an aging life care management company that's been in business in Maryland for nearly 34 years. Today, I'm testifying not only as a business owner and full-time care manager, but also on behalf of our National Association, the Aging Life Care Association. Because I've been in this field since 1993, I can actually remember when the Medicaid waiver was first introduced and was successful in getting a waiver for one of my clients. As it turned out, that would be the one and only time that I would be able to access the waiver for a client because of the length of the wait list. Today, I'm speaking for 3 different families that I've met with just this week. One, a son whose dad has PSP, progressive supranuclear palsy, and they've now run through all of the family's savings, and he wants to know how to keep his dad at home together with his mom and their grandchildren. I have 5 sisters who are trying to figure out how to pay for care for their mom who has Parkinson's and their dad who's recovering from cancer treatment, and for a daughter whose dad is 90 and has spent most of the last 5 months in the hospital and has less than $1,000 a month in income. And all of these families are willing to provide a lot of support, sometimes even a home, but they need the support of the waiver in order to do that. Each week we get calls like this, families wondering how to pay for the care for their loved one when they've outlived their assets, and they can't wait 6 months or 6 years for an answer to that question. With more than 20,000 Marylanders on the wait list today, and 10,000 baby boomers turning 65 every day, this is not a problem that's going to get smaller or go away. It's time to address the challenges of the waiver that have been ongoing for so many years now and pass House Bill 80 today. Thank you so much.
Our pleasure. Thank you for your testimony. Next, we have Morris Klein. Richard, is the person here?
I'm here.
Yes, good afternoon and welcome. Will you please get started?
Yes, hi.
Hi.
My name is Morris Klein. I am, good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. Thank you for your leadership and Delegate Colliston for sponsoring this important legislation. I'm an attorney in Montgomery County, Maryland, and I'm testifying in support of House Bill 80 on behalf of my organizations, the Elder Law and Disability Rights section of the Maryland State Bar Association and the Maryland DC chapter of the National Academy of Elder Law Attorneys, whose combined 500 plus members represent primarily senior and disabled adults. It becomes increasingly likely that as one ages, one needs help with activities of daily living. Some say 1 in 2 at age 85 need some help with care. The holy grail is to age in place. Virtually all of our clients want to live in dignity in their home and not institutionalized. Not only is it preferable, but in the age of COVID, it is safer than risking exposure to institutional care. We have had a dialogue with the health department on this issue, going back over 20 years to when Paris Glendenning was governor. Other states have managed to expand waiver services, but here in Maryland, we have 21,000 who are on the waiting list, one of the highest in the country. Maryland, who prides itself in being progressive in many healthcare policies, falls way, way short when offering persons a chance to age in place with dignity in their home. The issue seems to be one of cost. The costs get muddled because of transition costs and the fact that, at least in the short term, people in a nursing home will remain in a nursing home and the cost of additional persons receiving home care will add to that. According to the Hilltop organization, which is cited in our testimony, the cost will, at least in the short run, be 10 to 12,000 persons a year. But in the long run, as more persons use the waiver, fewer people will need nursing home care. Last year, the governor budgeted for 400 slots, and we understand there's an additional 400 slots this year. So therefore, we urge you to consider favorably this legislation. Thank you.
Thank you for your work. We really appreciate it and your testimony today. Next, we have Ms. Tiffany Love Rivers. Good afternoon, Ms. Love Rivers.
Hi, thank you, Madam Vice Chair. Members of the committee, my name is Tiffany Love Rivers, and I'm here in support and on behalf of my mom, Gail Love. Ironically, my mom filled my home with smoke during the Senate hearing. My mom has cognitive impairment due to dementia, the likely result of a brain aneurysm she had the week I was born. As a result of also caring for my grandmother before she passed, my mom has no valuable assets. I bought my home nearly 4 years ago to care for my mom, but I cannot also afford to pay for home care. I have been on FMLA work leave several months now to care for her full time. Prince George's County is the wealthiest Black county in the country, and yet the Medicaid waitlist is one of the worst. This lack of an effective process affects working families struggling to provide care and still pass down assets and generational wealth. I applied for the Medicaid waiver option through Maryland Access Point about 3 years ago. In 2.5 years, we received no correspondence. And in fact, I was never informed that we were placed on a wait list at all. I thought the questionnaire I completed was the application. With pro bono support from Susie, who just spoke, and others who we were finally invited to apply in October. The first letter I received explaining the process and services was after we applied in October, after the fact. Maryland's Department of Health stated they have a 6-month deadline to process that application. However, since the cyber attack, they did not respond to any communication for several weeks. 2 weeks ago, they informed me that they still cannot access their systems. There's no confirmation that they will meet that 6-month deadline, and I'm hearing Maryland is already behind applications by several months. Staying on FMLA, I'll run out of paid hours 6 weeks before Maryland's deadline, and this may force me to relocate. Alternatively, I may have to relocate to Rhode Island, where their staff is working from home, but they do not have this wait list, and they're processing applications in 30 to 90 days. But it will be very disruptive and traumatic to move someone with dementia. Also want to mention that nursing homes are not allowing visitors right now. I've had no help for years and we're still waiting. Thank you for this opportunity to speak, and I ask that you support House Bill 80.
Thank you for being here with us today, and we appreciate your testimony, and I'm sorry about what your mom is going through. Thank you. We actually now can ask some questions, and I see Delegate Kelly.
Thank you, Madam Chairman. And my question is actually for the bill sponsor. I have been following this issue for several years. I'm trying not to get emotional because I find this unconscionable. And I'm not going to give a speech because we're not allowed to. But I want to thank you for bringing this bill back year after year. And I guess I just want to ask, in light of the budget briefing we had yesterday, you know, the testimony that we just heard about Rhode Island doing better. I know personally how much better New York does at this from dealing with this with my in-laws. I'm embarrassed and ashamed at how Maryland is doing. It's really unconscionable. So what we heard from Mr. Klein is sort of this issue of transition costs. At some point, in order to stop being an embarrassment to ourselves as a state, we're going to have to face this and deal with this. Based on yesterday's budget briefing, can you think of a better time for us to do this than now? And also, what do you really think the transition costs will look like?
Just lost you, Delegate.
She's frozen. But can you start
Sure.
answering? Because she did
Sure.
ask you a question.
So absolutely, I cannot think of a better time. We are well situated financially, is what we heard yesterday, in order for us to absorb a lot of the initial cost. The transitional cost, as the department explains it, is the staffing that they need to actually do the rigorous kind of outreach and follow-up that they need to do with the individuals on the registry. They received funding, additional funding last year for additional staff, but they reported to me in November that they had not filled those slots yet. Then yesterday we heard in the briefing that they are being given additional staffing slots. These will really help if they use them strategically. The plan that they're using now is not working. And you can see it clearly from the numbers. Nothing is progressing. So we have to be more strategic in how we do this outreach. I would be willing to work with the department to look at what other states are doing to facilitate it. And I think, again, I want to remind folks that part of the issue of the calculating the cost is if you consider that all 21,000 are eligible, then yes, it's astronomical. But all of our data says between 20 to 30% are eligible. So now you're talking about 2,000 or 3,000 people on that waiting list. And we have that many slots right now. We need a few more, but we have that many right now. We could actually fill them if we had a strategic plan of how to coordinate our staffing, particularly with our community partners, in order to do the kind of outreach that needs to be done.
Thank you, Delegate. I don't see the Delegate Ariana Kelly. Are you back?
I came back. I heard Delegate Clausen perhaps answering the end of my question. Did you get the whole question, or did I freeze before then?
She got your question.
Awesome. Well, thank you. I don't have a follow-up. We can talk more offline, but I commend you and thank you for bringing this bill.
Thank you.
Delegate Bagnall, followed by Delegate Lewis Young.
Thank you, Madam Chair, and thank you for bringing this bill. I know that our aging in place commitment goes back to 1999 when we established the waiver program, and there was a fairly scathing article in 2018 in the Baltimore Sun about this issue. And one of the things that they highlighted was that there is no regular review process to determine if there are people on the list, not only that are ineligible, but also are deceased. And I don't know if we have a review process, and or if we increased our staffing, if we could at least get to a yearly review to determine if we have deceased members still sitting on that waiting list.
I'll go ahead and respond to that. In my meetings with the department, I've not been able to get a clear answer on how they're approaching the list in terms of determining, who is, still viable. There are many people on the list who are currently in nursing homes, and now they may have gone on the list 4 years ago. Now they need the intensive services of nursing homes, so they would not be eligible for these in-home services. Again, it's not strategic. It's sort of, we're making guesses based on the names that come in, et cetera. The approach does not seem very systematic to me at all. So that's part of the strategic plan that I'm interested in them developing in order to meet this need.
Thank you. Thank you, Madam Chair.
My pleasure. Next, we have Delegate Lewis Young, followed by our Chairman, Pendergrass.
Thank you, Madam Chair, and thank you for bringing this bill. Some of the stories I heard today sound all too familiar to an issue I've been struggling with for the past 3 years, with the inability of individuals with developmental disabilities to access self-direction. And the argument that we hear from the Department of Health is that the federal waiver doesn't allow it. And so we've gone to the federal authorities that manage that program who have said, yes, we do. So my question is, do you think the obstacles that you're facing are in part a debate over what the waiver allows or not? Or is it just the inability of the department to implement, or is it a combination of both?
I would suggest that the primary reason is the department's inability to deal with the issue. There may be, the secondary part, well, we don't think it's available to these individuals, I think would be very secondary. Primarily, and honestly, Delegate, I think in the past, the funding has been the issue. I mean, the first time I brought the bill 3 years ago, the fiscal note writer was saying that it was in the 20 millions of dollars to start it up. And now that fiscal note writer says we can start it at 1.5 million. So, and it's because we've, in our talking about it over the last 3 years, we've become much more cognizant about what it really means and how many people need, how many people actually qualify.
Yes, thank you for that answer. I've seen big debates and fluctuations in the fiscal note on the self-direction issue as well.
Right.
Thanks.
Thank you, Delegate.
Chairman Pendergrass.
Thank you very much, Madam Chairman. I'm not sure there's anyone here to answer the question, so I'm going to ask it anyway, and maybe someone will surprise me. Is there anyone here from the Department of Health to answer the questions we have about why this is in such bad shape? And is it important enough to the department to get this going, to be here today, to explain it to us, and to work with us. And if there's no answer, I'll accept that. But if there's somebody who is quietly sitting there monitoring and ready to answer those questions, I would love to have the answers.
Richard, is Heather Check here? I know that they submitted an unfavorable written letter.
They
Is she
did.
here? Is she here to answer some of these
She
questions?
specifically chose to not testify, which is why I'm asking why they're not here. This is a very important question to a lot of people. I was considering asking Mr. Klein if he could opine on why they would do that, but I decided that it would be unfair to put a citizen in that position. So I decided to ask the empty space that we have right now.
And it is empty because she's not here.
Thank you very much. I think the no answer says everything.
Thank you, Chairman. That's a great question. Next, we have Delegate Steve Johnson. Delegate Steve Johnson, please.
Thank you, Madam Chairman, and thank you, Delegate, for bringing us this bill. Delegate Collison, I was just looking over the Health Facility Association of Maryland. They're favorable with amendment, and they had some concerns about stating clear timelines and eligibility criteria for participation. And they had concerns about the Maryland Department of Health. They wanted to prohibit them from cutting rates or utilization in other Medicaid programs to fund the home and community-based health care. Can you speak a little bit about those, please?
I'm willing to work with HFAM on the amendments, but in terms of the concern about cutting rates, at this point, I don't see that as a possibility, given where the state is financially, given where the Medicaid program is financially. We heard about this yesterday, that the funds are there, particularly with respect to the regular Medicaid, not the waivers, but the regular Medicaid, the enhancements that we've received. So we now are in a place where everyone who is, all of the folks in institutions, the long-term care institutions should remain whole the way they are, and the community waiver services would be paid for separately the way they always have been. So I don't think that's a problem. The timelines issue, if we need to work on that, we are, I'm certainly open to that.
Thank you, Delegate. That's the answer I was looking for, that yesterday we heard the funds are there.
Right.
So thank you. Thank you, Madam Chairman.
Our pleasure. Are there any other questions for this bill?
Move the bill.
Seeing none, this concludes the bill hearing on House Bill 80. Thank you, Delegate Collison. Next, we have House Bill 6, which is Delegate Collison and Delegate McKay, and Delegate McKay will go first. And it's titled Maryland Medical Assistance Program, Dental Coverage for Adults. Good afternoon, Delegate McKay.
Oh, good afternoon, everyone. I hope everyone is having an awesome and wonderful afternoon. Chairman Pendergrass and Vice Chair Melnick and the esteemed members of the Health Government Operations Committee, for the record, I am the self-proclaimed dental delegate Mike McKay, and it is my honor to be the first to present today on HB 6, Maryland Medical Assistant Program, Dental Coverage for Adults. I grew up in a family where we went to the dentist twice a year, even when it was a financial struggle. I've carried the values of access to dental care through my whole life and through my legislative career. Each year I've been in office, we've made incremental progress in increasing the access to dental care. This is the year that we reach the finish line. It's time to ensure that all adults with Medicaid can get dental services they need to stay healthy. Today, you will hear the need for medical dental coverage for adults. You will also hear some of the options for financing such coverage, such as directing funds from past settled lawsuits or maybe budget surpluses. About 800,000 Maryland adults, nearly 1 in 5 Marylanders, do not have reliable source of dental coverage that meets even the basic healthcare needs. One topic I would like to address is substance abuse recovery and the effect of lack of oral health has on one's ability to become clean. Some drugs, such as ecstasy, cocaine, can lead to jaw-wrenching tooth grinding and can result in cracked or broken teeth, as well as headaches and jaw pain. Now, being high on drugs could also make you less likely to remember to brush your teeth regularly and could lead to gum disease, tooth decay, and even tooth loss. Some may have, and many have seen, the HBO show Euphoria. Now, I'm telling you that this show is a parent's worst nightmare. And it is centered upon a group of high school friends, each with their own problems handling the excess of drugs, drinking, and sex. But this ensemble story is focused on pain. Rue Bennett, a teenager struggling with a substance abuse disorder. Through watching this, there are very, very hard times to watch. Euphoria balances the brutal honesty with the empathetic chances of a substance abuse recovery person. If you really want to understand the struggles of being an addict and the difficulties managing the pain from poor oral health, then I suggest you watch HBO's Euphoria. Now, viewer discretion is advised, and this must be taken very seriously. In closing, I urge for a favorable report from this committee, because as I mentioned before, this is the year to reach the finish line. It's time to ensure that all adults with Medicaid can get the dental services they need to stay healthy. Delegate Collison?
Thank you, Delegate McKay. So I want to just emphasize dental health is inseparable from somatic health. Unfortunately, we viewed it frequently as cosmetic, but it's that perception that led to the death of Diamante Driver. For the cost of an $80 tooth extraction, that child died. And indeed, the state spent $250,000 in hospitalization and surgeries because of the infection that was not treated by that $80 extraction. And that can happen to anyone at any age. There are lots of studies that show the relationship between dental health and chronic diseases like diabetes, heart and liver disease, and arthritis. And our total cost of care agreement says that we want to reduce recidivism. We can do that with dental care by assuring that folks have this access to these services. We've made lots of serious commitment to healthcare equity. This is our chance to prove it. Black adults have the highest rate of emergency department visits for dental pain. And most of the time, these do not treat the problems, they only address the pain, and they will return to the emergency room. We stepped up for children living in poverty in remembrance of Diamante Driver. It is now time to step up again for the family members, and I humbly request a favorable report. Thank you.
Thank you, Delegates McKay and Collison, for bringing this bill. Next, we have Dr. Nakia Staley. Good afternoon, Doctor.
Good afternoon. Thank you, Madam, and greetings to everyone that is present. Thank you for having me speak today in favor of House Bill 6. I am, as she said, Dr. Staley Neither, and I'm the owner of Special Care Dentistry in Prince George's County, Maryland. I've also been a provider for the Maryland Medicaid program since 2005, since I opened my practice. So as in full support, this bill will allow myself and other of my colleagues to take care of the oral health needs of our community. As we know that most of our population lives with chronic oral infection due to gum disease and tooth decay. These infections can lead to stroke, heart disease, diabetes, negative pregnancy, and birth outcomes. And unfortunately, even death. I have witnessed this in my practice personally, as I was treating an 8-year-old little boy last summer who was coming to the dentist with his mother. And as we stated, the program for children is quite extensive and covers services And one day, this little boy presented with his aunt, and when asking where's mom, I was informed mom died because she wasn't able to get her tooth pulled. She'd been going back and forth with the program and not having coverage to take care of her. So it's very devastating. I can't imagine, if you could imagine how it would feel having this mom in my office and not get services because of her lack of insurance and lack of coverage. Also, just in my office today, I spoke about a lady named Ms. Daring. She has the Maryland Medicaid adult program. She's on the pilot program, and however, has not been able to get the services that she needs. She can't get teeth replaced. She's currently having weight loss issues that she's not able to masticate and chew her food. And then, the plan does not cover any type of tooth replacements. So, and I share this sentiment with everyone here that has spoken that, this program is vital to the health, not just the oral health, but it's systemic health of our community. And, as oral physicians, I very much look forward to continuing with this program and well as offering further dental benefits as needed. Thank you for hearing me today.
Thank you, Doctor. I appreciate your testimony. Next, we have Ms. Gretchen Graves. Rachel, is she here?
Sorry, I thought I was unmuted.
Okay.
Can you hear me?
Yes, you have 2 minutes. Will you get
Okay.
started, please?
Okay. Thank you, House Chairwoman Pendergrass, Vice Chairwoman Pena Melnick, and our House Sponsor Delegate Colson for giving me a chance to speak today. My name is Gretchen Graves. I live in Hagerstown. What did it mean to me to get the 2019 dental waiver? The waiver represented freedom, hope, and a lifting of the weight of trying to find an affordable dental home, especially after our Washington County Health Department closed its sliding scale dental office. As a recently divorced mom in 2019, suffering from depression, receiving my enrollment card eased some of my anxiety about my dental health. It had been 20 years since I had a job offering dental insurance. There were many positions I worked just under full time where the company didn't have to offer me health insurance. And this forced me to go much longer periods of time between cleanings simply because I struggled to find an affordable dental home. I have more fillings now, I'm convinced, because of not having regular care. When I was pregnant with my son in 2013, I was able to see a dentist through Maryland Healthy Smiles program. I still remember my excitement at being covered and also my feelings when the dental program ended after having my little boy. I had so many mixed postpartum emotions. I felt like nobody cared about me as a new mom and my dental care. At the same time, I was so grateful that my son had dental coverage through Healthy Smiles. I've always wanted to be the best role model I can be for my son. I feel that having the opportunity to see a dentist on a regular basis allows me the chance to show him that I'm practicing what I preach about how important it is to brush and floss and see the dentist for regular cleanings. I've always been proud of Maryland for what I see as its progressiveness. When I found out Maryland is only one of 3 states not to offer dental to its adult Medicaid recipients, I see this as a wonderful opportunity to correct this oversight embarrassment. I'm proud of my smile, the dental care I receive, and want the same dental coverage for others. As a single mom with mental health issues, this coverage takes a huge weight off my shoulders and gives me hope. And I come before you today to plead for all the other Medicaid recipients who do not yet have this basic needed dental benefit. And I implore you to be on the right side of Maryland history. Thank you.
Thank you for sharing your story. It makes a difference, okay? And for speaking on behalf of other people that need this care. We appreciate it. Next, we have Dr. Monzella Williams. Good afternoon, Dr. Williams.
Good afternoon. Hello, Madam Chair and members of the committee. It is my pleasure to join you today in support of HR 6. I want to lend another medical perspective on this important dental legislation. Practicing medicine in Maryland for 13 years, I proudly represent West Cecil Health Center, a federally qualified health center in Conowingo, as well as the Maryland Academy of Family Physicians. I have seen firsthand the suffering and medical consequences due to lack of basic dental services for our adults on medical assistance. I also know all too well that the inadequate treatments I can provide for these patients. Put simply, primary care physicians like myself have only 3 tools at our disposal: antibiotics, pain medication, and a quick referral to our dental colleagues. While antibiotics and pain medicine can be very helpful, overutilization is fraught with any number of health complications and the knowledge that it is simply the inadequate treatment for the underlying pathology. And even when patients are not in acute pain, the inflammation in the mouth can contribute to inflammation we see in other parts of the body. Type 2 diabetes, high blood pressure, blockages in the vessels of our heart or brain are all impacted by the health of the oral cavity. As you may know, many of the medicines we use to treat uncontrolled chronic diseases are very, very costly. As a chief medical officer, I understand hard choices must be made with our healthcare resources. The benefit of broadening dental care to our adults on medical assistance is evident at the clinical level when considering both long and short-term goals. We need to make referral to our dental health professionals, which is the safest, best, and most cost-effective treatment, affordable and available. Thank you.
Thank you for your service to the people of Maryland. We have next, Mr. Philip Demura. Good afternoon, sir.
Thank you for inviting me to discuss our study entitled Dental Services and Health Outcomes in the New York State Medicaid Program. We sought to investigate the relationship between the utilization of dental care and subsequent health service utilization and associated healthcare costs, comparing cohorts of New York State Medicaid members receiving preventive dental care, those receiving extractions and/or treatment for dental disease, and members receiving no dental care. Additional analyses were conducted to evaluate the same relationships among members with selected chronic diseases. And among our cohort of about 500,000 Medicaid members, we found that all-cause ED rate ratios and all-cause inpatient admission rate ratios were significantly lower for members who receive preventive dental care compared to those who receive treatment for dental disease, with reductions larger for inpatient admissions, particularly among members who receive preventive dental care. With regards to cost, the average adjusted ED cost differences across cohorts was small and mostly not significant. However, the average inpatient admission costs per member were significantly lower for members receiving preventive dental care, with savings ranging from about $263 to $380 on average per member. For each additional preventive care visit received, we found a 3% reduction in relative risk of ED visits and a 9% reduction for inpatient admissions. Each additional preventive care visit significantly lowered costs for all outcomes and was especially pronounced for total adjusted healthcare costs, with $236 of savings and inpatient admissions costs of $181 on average per member. In our analysis of selected chronic diseases, preventive dental care was associated with lower ED and inpatient utilization rates and costs per member in all disease cohorts. Cost savings were most pronounced for inpatient admissions for members receiving preventive dental care without treatment, ranging from $539 to $1,950 on average per member. So in conclusion, we found that the utilization of preventive dental care was associated with reduced ED and inpatient admission rates and inpatient admission costs. Thank you for allowing me this time to share our findings.
Thank you for sharing your findings. We really appreciate it. Next, we have Ms. Robin Elliott.
Good afternoon. I am Robin Elliott. I think you all know me. I appreciate your time. I'm here on behalf of the Maryland Dental Action Coalition. I am closing the panel by really emphasizing that Maryland is one of just 3 states in this country that does not offer systemic dental coverage. The other 2 states are Alabama and Tennessee. And given our focus on total cost of care and primary care medical home models, ultimately those models won't work unless we plug this hole for dental. As my colleague from the New York State Department of Health just showed us, is that offering dental coverage and people getting dental services saves money. there are multiple clinical reviewed evidence-based studies that show there is significant savings, particularly around chronic disease, also around substance use disorder treatment. You have in your packet the Maryland Dental Action Coalition's testimony. There are a couple key things I wanted to point out. I know you have lots of testimony from individual organizations. There are also dozens and dozens and dozens of other organizations signed on to our testimony, many of them substance use disorder providers and advocates, as Dental McKay attested to. In that study, there are also 5 pages of research citations to point to this evidence that dental makes sense, it improves outcomes, it saves money. And then finally, I just wanted to thank you for your time and your attention to this matter. We've made progress in the past 5 years, but it is really time. We implore everyone, we appreciate your time on thinking about finally closing this gap. Thank you.
Thanks.
Madam Vice Chair.
Delegates, thank you. Thank you, Richard. Delegate Semple Hughes, followed by Delegate Lewis Young. Thank you, Richard.
Thank you, Madam Chair, and thank you to the bill sponsors. This is certainly needed, and I know our committee's been very much advocates for trying to make this happen. I wanted to ask you, Delegate McKay, this may be something that you already know off the top of your head, but it's my understanding that now long-term healthcare facilities are offering this as an ability for their patients to get dental care now. It's like it's just something new. Is that correct? I'm only aware of it at one facility, but I just wanted to see if that was one of the progresses that have been made that you've been working on. And the last thing I'll say about that, but what I have also learned is that it has led to the fact that people have not had care for so many years that now the program that is being offered is only really doing extractions because of the lack of care. Mm-hmm. Is that one that you're familiar with, Delegate McKay?
Delegate McKay, will you please unmute yourself?
There we go.
There we go. I'm sorry.
It's okay, it happens.
I'm trying to do a subcommittee with PSA is the same, so I'm listening to one and the other.
Okay, well then maybe Delegate Cullison can answer it. I just wanted to.
Thank you for the smart end of the two of us. I'm just the eye candy. Delegate Cullison.
And I'm actually going to turn your question over to Robin Elliott, who would know, be able to respond better about how the expansion has gone.
What has happened?
Elliott.
Okay, thank you.
All right. So that is a great question. Thank you. We have added 2 adult populations in the past couple of years for dental. One of them is, I think, what you're referring to, and that is adults under the age of 65 who are duly eligible for both Medicaid and Medicare. And so at any given time, that's around 30,000 people or so. What you may have heard is there is a cap on the annual expenditures for that program. And so sometimes that really can limit how much can be done within any given year. Certainly people who have complex dental needs, $800 isn't enough, but we're very appreciative that that program is there because we literally haven't had anything for Medicaid enrollees since about 1991. The other group of people, and this is really thanks to your committee and so many of the advocates who are also on the call today, is Maryland just started postpartum coverage of dental. This is just going to be an amazing opportunity to make sure that people who struggled to get access to dental care because they were pregnant, and that's, can be many challenges, are now going to have the opportunity to get dental care. And I wanted to acknowledge the testimony of Gretchen Graves, who spoke to the importance of that issue.
And just a quick follow-up, if I may, you had mentioned that the individuals under 65, but what about those who are over? There's still nothing for them, is that correct?
That's correct. There may be individual facilities may have programs where they are able to bring in a dentist into the facility. It may be what you've heard about in your area. They're wonderful programs, and we should do more of that. I think some of the challenges are in long-term care is, do you bring the services in because people are less mobile, or can you take people out? And of course, there's the coverage issue. So we would love to follow up with you more on that.
Sure. Thank you. And thank you, Madam Chair.
My pleasure, Delegate. We have Delegate Lewis Young, followed by Bagnell, then Delegate Hill, and Delegate Krebs. Delegate Lewis Young.
Thank you, Madam Chair, and
My
thank
pleasure.
you, sponsors, for bringing this bill. I see that there are 45 favorables on this bill and 1 unfavorable on this national best practices in healthcare and common sense bill. So I will repeat the committee chair's question from the last bill. Is there anyone here that can speak to the unfavorable testimony and the rationale behind it?
There's no one, Delegate.
Thank you.
May I interrupt, Madam Chair?
Yes, Chairman.
I think from now on, when we ask the question, we're going to ask it of the Secretary of Health. Because I think that's where the buck stops, if not the governor. So from now on, that question appropriate to answer goes to the Secretary of the department who makes the calls, unless, of course, it's the PR department, which would be an unofficial way of doing things. Thank you, Madam Chair, for your indulgence.
Thank you, Chairman Pendergrass. Next, we have Delegate Bagnell.
Thank you, Madam Chair, and thank you to everyone for advocating for this bill. I think my question is for Phil Demura, but if there's someone else more appropriate. But Phil, I really appreciate the data comparisons you gave us, and there's more in the packet. But preventative care is always it's always challenging to calculate the long-term savings because there's upfront investment, but then you have a long-term savings over, the life of a person when you are detecting early chronic illness, avoiding emergency care, avoiding those comorbidities. But since you have implemented this program in New York, do you have a sense of the long-term savings over the lifetime of an adult who is enrolled in this program?
No, I don't think that's not exactly what we looked at in this study. For this study, what we did is we looked at the services that members received in years 1 and 2 of the study, and then measured their outcomes in year 3 to see if there's reductions in service utilization and costs in that 3rd year based on their first 2 years of dental services. And that's where we found the savings and reductions. We did not look at any kind of long-term projected, savings or reductions in utilization.
Madam Chair, if I could just have a quick follow-up.
Sure.
So these savings are reflective of a 3-year study of investment.
Right. The savings are reflective of the 3rd year. So those who receive preventive dental care in year 1 and 2, we looked at their utilization in year 3 and compared those who received preventive care to those who received no dental care in the first 2 years. And those who received preventive care had reduced utilization and costs on average compared to the members who received no dental care.
Thank you. That's an astounding outcome for such a limited time frame.
Yeah, thank you.
Thank you. Next, we have Delegate Hill, followed by Delegate Krebs.
Thank you, Madam Chair, and I want to thank you and the committee chair for a day of yes bills. But so this question, I don't know, Robin, it may be you, it may be Dr. Demora, sort of following up on Delegate Bagnell. So there was a study, United Concordia Oral Health Study, and it showed, looking at 330,000 insurance records, it looked at long-term and talked about annual savings in health of overall $5,600. In hospitals, hospitalizations dropping by about 40%. They talk about where oral cancer is concerned, lifetime savings of 495 million, emergency room visits 826 million, 5 billion in terms of lung disease savings, both prevention and mitigation, and a 7 billion savings. Annual savings could equal $7 billion if 40% of pregnant women received oral care, according to the cost of periodontal therapy. 39 billion when we talk about diabetes. So as one who has treated dental illness that became somatic cellulitis infections and other things, that seems consistent with me. Robin or Dr. Demora, are those numbers pretty much in line and would speak to some of the health department's stated concerns about what this would cost? Would you find those numbers to be plausible, reasonable?
Delegate Hill, we have looked at so many sources of data, and I don't have that particular study right in front of me. But every single study is consistent that there are savings. Chronic disease is always listed, cardiovascular, diabetes, cognitive impairment, reducing the risk for stroke. In Maryland, we have a study that shows that Maryland Medicaid spends just over $11 million a year on ED visits, as well as inpatient admissions for diseases that could have been, dental diseases that could have been prevented. So the literature is very consistent. You'll see slightly different estimates, of course, when you do those types of studies, but it's incredibly clear. There was also a study that's very important that just came out from the University of Utah, which confirms what the substance use provider community knew intuitively. But people who get dental services while they're in treatment stay in treatment twice as long, and that their treatment outcomes are more successful. And then when they finish, they're more likely to be employed and they're more likely to have homes. So the evidence is out there. And so I thank you for your question. And we have lots of additional data I would be happy to share and discuss with you.
Thank you very much.
Thank you. Next, we have Delegate Krebs, followed by Delegate Kelly. Delegate Krebs.
Thank you, Madam Chair.
My pleasure.
This is a subject that has been near and dear to this committee's heart for many, many years. And one of my questions and my concerns is this is just for Medicaid. And I do know there's a lot of folks, vulnerable citizens, that are not necessarily Medicaid eligible. They're insured, but this is not covered through their insurance. But I do recall that last year we put together a task force to come up with some of these issues that my colleagues right before me just expressed a bunch of data and information, and it's all comprehensive, and I appreciate that. But I thought we had passed a committee on oral health task force to look into some of those things, and for all people, that whether they're underinsured or Medicaid eligible. And I wanted to know if anyone on the committee serves on that and what the status of that task force is. And while if they're on the task force, I did notice that on the MCOs, they in their testimony, they said that some of our Maryland Medicaid MCOs voluntarily elect to offer limited dental services. And it'd be nice to know how they're able to do that. Obviously, they feel it's necessary, and why that can't be expanded to other MCO providers or other types of insurance. So I'm asking on an update on this oral health task force, and would they be able to give us some of this information that we're seeking?
So may I, Madam Chair?
Yes.
I'll take that. Okay. Thank you, Delegate Krebs, for the question. I think Delegate Bagnall is on the oral task force, so you can maybe have a conversation offline in terms of where they are.
I was going to say, if I may, that will be offline because we don't ask questions of our members, and that's information that can be requested to get that update.
Right. Thank you.
Okay.
But in terms of waiting on the oral task force, their report isn't due for 2 years. So then whatever policy we might come up with is at least 3 years delayed. We've got people now who are ending up in the hospital because of health, dental health issues. And as we're hearing now, this is the moment in terms of, first of all, it's the right thing to do. And secondly, the funds are there. The funds are there now. We heard this. And if we begin it now, we begin our savings now. And there've been several speakers plus several questions that indicate what that level of savings might be. So that's why I want the oral task force to continue its work and to, and look at perhaps, implementing this program, how it affects the long range and the total context of dental health in Maryland. And, I'm a believer in more dental health services from our within our insurance plans, but those are all things that are going to be worked on by the task force. I think we need to do this now. I think we need to get started and make sure that people have the opportunity to get these services before they lose more teeth or they end up in the ED room, or in the case of Diamante, end up seriously ill.
No, I thank you for that. I just hope the committee looks at this comprehensively and not just for the Medicaid, because it's a much bigger issue.
Yeah,
and
absolutely.
I think we should make sure we're careful. We've been talking about this for 16 years and I've been on the committee. So I thank you.
Thank you. Delegate Kelly.
Thank you, Madam Chairman. I wanted to direct my question actually to Delegate Coulson, although you can punt it to Robin or someone else if you think it's better. But so I'm looking at the fiscal note, and it's a 60-40 federal state split, which I like. 82 million in 23, 166 million in 24. Is there any further work we can do to bring that down anymore? Is there anything we can do to work on that? I love the bill. I'm just asking. It's sometimes I find that, as you saw with your previous bill, a little bit of refinement can help us bring the number down a little.
And I am going to punt to Robin Elliott, but thank you for the question, Delegate.
Thank you.
So I think Legislative Services does a great job with their fiscal notes, and they used a very useful study that was done by Hilltop that actually the Maryland Dental Action Coalition commissioned. That study was done in 2016. And so I think we've got a lot more information available to us now on dental utilization, on costs, and it probably makes sense to do an update. I'll mention a couple of quick things that make me think that the fiscal note is probably somewhere in between, as we often find. There was a study done by the Health Policy Institute, which looked at all states that don't have comprehensive yet. And that estimate was that it would cost $57 million in total funds for Maryland to implement comprehensive coverage with a savings. They actually calculated a savings of $24 million. Virginia, just this past year, implemented comprehensive adult coverage. We looked at their fiscal note. I think Virginia's population is approximately our population. I'm sure there's some differences, but their fiscal note for a full year was $43 million in general funds and $102 million overall. So I think that gives us a sense that there certainly is a range of how you do fiscal estimates, and there's certainly probably some work that can be done to see if we can really hone in using current data on what the actual expected cost would be.
That's very helpful. Thank you so much.
Thank you, Delegate. Thank you, Robin. I don't see any other questions on House Bill 6. So this will conclude the hearing on House Bill 6. Thank you so much, Delegate McKay, for being with us today. Next, we have House Bill 534, Delegate Bandari, and its title, Maryland Medical Assistance Program, Self-Measure Blood Pressure Monitoring. Delegate Bandari, good afternoon, and you can get started.
Thank you, Chair Pendergrass, Vice Chair Pena Melnick, and member colleagues of the Health and Government Operations Committee. Good afternoon. House Bill 534 would require the Maryland Medical Assistant Program to provide coverage for self-measured blood pressure monitoring beginning in 2023. This would give people with high blood pressure, also known as hypertension, the tools to take control of their own health and significantly reduce their risk of heart disease or stroke. An estimated 1.5 million adults in our state deal with hypertension, but almost half of these individuals, about 700,000, according to CDC estimate, don't have the condition under control. Everyone has their blood pressure taken by the doctor, but some people need more regular monitoring. We have the tools to do this from home, but inconsistent insurance coverage and provider reimbursement is a barrier many people face in better managing hypertension. It is also important to note the fiscal note. Estimated increases in Medicaid expenditure as a result of this bill do not reflect the saving, which would be associated with a healthier population relying less on treatment for more serious health outcomes. Research has shown that self-measured blood pressure monitoring combined with clinical support from healthcare providers is effective in reducing hypertension, improving patient knowledge, enhancing adherence to prescribed medication, and improving the responsiveness of our healthcare systems. This bill will help so many people improve their own health and also have the peace of mind which comes with being more informed on these life and death issues. House Bill 534 would help those 1.5 million Marylanders with hypertension live healthier lives. We all know someone is struggling with hypertension. We may or may not know someone who had died from complication of the condition. We must do everything we can to avoid this outcome and stepping up our coverage through the provisions of HB 534. It is a significant step in this direction. I will also note that this bill had a Senate hearing yesterday with no opposition. To my knowledge, there is no opposition on this bill today too. And included in written testimony are favorable reports from MedCai, the Maryland Department of Health, and the Maryland Association of County Health Officers, and many other written testimonies based on the clinical evidences. With that, I request a favorable report from the committee. Madam Chair, Ms. Laura Hell, American Heart Association, is the first one to testify on this bill. And I would like Laura to use my remaining time as well.
Thank you, Delegate Bandari. Ms. Laura Hill, you have your 2 minutes plus 1 minute and 46 seconds. Welcome to the committee. Will you please get started?
Thank you, Madam Chair, Madam Vice Chair, and members of the committee, and thank you, Delegate Bandari, for your sponsorship of this important legislation. My name is Laura Hale. I'm the Director of Government Relations with the American Heart Association, and we extend our strong support for HB 534. We have seen, and as been stated, this legislation is really essential for our Medicaid patients, as we found that having both clinical support as well as a blood pressure device at home is really effective at reducing high blood pressure, also known as hypertension. We have seen with this as well that this really improves patient outcomes as patients truly need that support in being able to properly manage their blood pressure. The fiscal note overall, as was already noted, is we think a little high, but we hope to see a number of people take it up. But being able to have real savings between stroke as well as decreases in going to the hospital are things that we can definitely see from putting this legislation forward. I also wanted to talk as well about when we think about Medicaid, we may think of older patients at first, but I wanted to bring us most closely to our maternal and postpartum patients. I wouldn't be before you all today, as I had a little girl back in August, if I did not have support from my physicians to be able to manage my blood pressure as I developed preeclampsia and experience with that postpartum. We need to make sure that for all of our Medicaid patients, that they have the support that I was able to have, so that we have longer, healthier lives for all of those that we see. And we really wanted to make sure to bring that home today with this legislation. This really makes sense. And we know that having both the clinical support, which is outlined here, as well as blood pressure devices, that we will see wonderful patient outcomes. Thank you so much for your time today, and we urge a favorable report.
Thank you for being with us today. We appreciate your testimony. Next, we have Ms. Chanda Brown. Good afternoon, ma'am.
Good afternoon. Thank you for the opportunity to speak, Madam Chair, Vice Chair, and honored members of the committee. My name is Chanda Brown. I'm a licensed social worker and founder of Zen Lately, a small health and wellness business in Baltimore City. I'm here today in favor of House Bill 534. I've developed programs and provided services to countless Medicaid recipients in Baltimore City for nearly 20 years. And I'd like to provide a clear picture of what I encounter far too often as a direct service worker. I ask that you all imagine arriving to work and you're met with your client on the elevator with his genitals exposed, urinating, experiencing disorientation and mental confusion, being ridiculed because the behavior was presumed to be drug abuse. Upon further assessment by emergency medical technicians, you learn that his blood pressure is uncontrolled, and further conversation with him, you learn that he's really struggling to monitor it without support. He also expresses anxiety around medical bills due to ambulatory rides as a result of his hypertension. I'm here to bring awareness on his behalf and the countless others struggling to control their blood pressure, because he is unfortunately no longer with us. He succumbed to his chronic health conditions that were directly related to his hypertension. Self-measured blood pressure monitoring not only improves one's quality of life, it could potentially reduce healthcare costs and ultimately saves lives. I urge a favorable report on House Bill 534. Thank you.
Thank you so much for your testimony today, Ms. Brown. Next, we have Mr. Athol Morgan. Athol Morgan?
Yes, can you hear me?
Yes, we can. Good afternoon.
Good afternoon, Madam Vice Chair, Madam Chair, members of the committee. Thank you, first of all, for the opportunity to speak to you today. I'm Dr. Athol Morgan. I'm a cardiologist. I'm a member of the board of the American Heart Association. I've been practicing cardiology in West Baltimore for more than 25 years. And I appreciate the opportunity to lend my support to House Bill 534. I came to Maryland in 1982 to attend medical school at Johns Hopkins, and I've been here ever since, and I've really appreciated that this is a wonderful state for a guy like me.
Mm-hmm.
High blood pressure or hypertension is often referred to as a silent killer, and for far too many of my patients, it's something they struggle with trying to get it under better control. In my years of practice and through the research literature, what I've learned is that when a patient is able to have the clinical support combined with the ability using their own home blood pressure monitor device to measure the blood pressure themselves, they're much better able to have success at monitoring and managing the blood pressure. It's a silent disease and people are unaware of it often when their blood pressure is high. But when they can monitor it themselves and know that it's high, then they are more willing to take their medications. They need clinical support to understand these devices and to understand the measurements and the numbers they're getting, and to help them make progress towards the goals that they have set for themselves and that their provider has set for them. I've had many patients express a completely new understanding of the problem once they're able to monitor the blood pressure themselves, get feedback from their providers about the blood pressure and how they're doing. They're more compliant with their medications when they're able to track the effects of the medications and monitor the progress they're making. If they have a provider who can help them monitor it as well, it's incredibly important. One of my patients, I'd become quite frustrated because her blood pressure was always high at the office. And once we had her monitoring it at home, we found that actually it was much better at home. And I told her, well, it looks like your blood pressure is not actually that high. You have this white coat hypertension. And she said, well, doctor, it appears that you're the one who has been sending up my pressure all this time. So this was really a game changer for her after years of frustration. I believe this technology is as far as blood pressure control is going, the single biggest real advance to management in my career during my time. As a physician, me and my team, we get pulled in many different directions every day. And the ability to properly catalog the time that we spend educating patients, supporting them, helping them to manage their blood pressure is essential. This legislation will allow for new codes to be turned on so that the providers can be reimbursed and can help keep track and document the support that they give to these patients. And this is going to prove to be incredibly important. So for all the reasons I mentioned above, I urge that you favorably support House Bill 534, which gives us a magnificent new tool to help the patients manage this deadly disease. I appreciate your time and your ear in listening, and please do pass this bill. Thank you.
Thank you, Doctor, for your service to the state of Maryland. We really appreciate you and for the work you do. Next, we have Ms. Christy Waterman. Ms. Waterman from the Maryland Nurses Association. Are you here?
I am. Good afternoon, everyone.
Good afternoon.
Thank you, Madam Vice Chair and committee members. I am Christy Simon Waterman. I am a family nurse practitioner and the president of Maryland Nurses Association. I am urging you to vote in favor of House Bill 534, Maryland Medical Assistant Program Self-Measured Blood Pressure Monitoring. Monitoring blood pressure at home can save money and save lives. It saves lives because it is associated with better blood pressure control. It saves money by reducing medications as well as provider and emergency department visits. I once cared for a woman not yet 30 years old who was 37 weeks pregnant and scheduled for an office visit in 6 days. She checked her blood pressure at home, saw it was high, and came to the office where fetal distress was discovered. This patient was sent directly to the hospital where a C-section was performed. Her son was delivered with a low ABGAS scores, but was successfully resuscitated. High blood pressure, also known as hypertension, is a threat to the health of many people. Treatments may not seem urgent and is easily put off by patients because hypertension does not cause immediate obvious symptoms. The American Heart Association reported high blood pressure in 6% of people aged 20 to 44, 34% of those aged 45 to 64, and 60% of those 65 and older. A study published in the Journal of Hypertension found net saving achieved with home blood pressure monitoring ranged from $33 to $166 per person in the first year. In 2020, the American Heart Association and the American Medical Association published a joint policy statement supporting self-measured blood pressure monitoring at home. The Maryland Nurses Association joins them and other healthcare providers in urging that Maryland Medicaid patients be reimbursed for blood pressure monitoring kits. Maryland nurses urge you to vote for House Bill 534. Thank you for your support.
Thank you for your testimony today and for the work you do. Are there any questions regarding House Bill 534? Just checking the participants to make sure. I see none. Thank you so much. Well, this will conclude the bill hearing on House Bill 534. Thank you for being with us today. Next, we have House Bill 353, Delegate Landis. It is titled Maryland Healthcare Commission User Fee Assessment. Good afternoon, Delegate Landis. You're muted.
I am so sorry.
It's okay. No need to apologize. It happens to all of us.
Yes.
And this is your first bill hearing with us.
Is.
So we're
It
excited.
is. Thank you so much.
Our pleasure.
For the record, I'm Delegate Cheryl Landis here to present House Bill 353, Maryland Healthcare Commission User Fee Assessments. The bill increases the maximum amount from 16 million to 20 million of user fees the Maryland Healthcare Commission may assess against hospitals, nursing homes, insurance payers, and healthcare practitioners to cover the actual documented direct costs of fulfilling the statutory and regulatory duties of the commission. Four key functions of the Maryland Healthcare Commission are: number one, to plan for new healthcare facilities and services; number two, to develop quality reports on the services provided by hospitals, nursing homes, ambulatory surgery centers, and insurance companies; number three, to expand the use of health information technology; and number four, to conduct healthcare policy studies needed by state policymakers. With that, I respectfully ask for a favorable report on House Bill 353. And now to explain why an increase in the user fee is needed and to answer all questions, I yield the remainder of my time to Mr. Ben Steffen, Executive Director of the Maryland Healthcare Commission. Thank you.
Thank you, Delegate Landis. You are a pro. Impressive. Mr. Ben Steffen, good afternoon.
Thank you, Vice Chair Pena-Melnick, Chair Pendergrass, members of the committee. Ben Steffen, Executive Director. I want to say, first off, listening to the committee hearings this afternoon, I was extremely moved by the statements of all of the healthcare practitioners that spoke before you. I'm honored to hear their work and recognize them as we are in Healthcare Heroes Week today and for the remainder of this week. The Healthcare Commission is requesting the committee pass House Bill 353 that will raise the Maryland healthcare assessment cap from $16 to $20 million. As the delegate noted, we have the ability to assess four industries: nursing homes, hospitals, insurance payers, and healthcare practitioners. We do that to meet our key statutory functions, which she very ably and with a lot less nerve than I have today outlined. But in addition, I wanted to highlight to you areas that go beyond our statutory authority that we've been asked to take on over the last several years that are key factors in driving spending of the Healthcare Commission. They include the establishment of the Prescription Drug Affordability Board. As you know, in 2019, the General Assembly established a new affordability board to examine and take steps to rein in prescription drug costs. There was no financial vehicle to fund the board. The Healthcare Commission, at the request of the governor, stepped in and took that on. We also are taking on the responsibility of helping to fund the primary care initiative here in the state of Maryland, the MDPCP Program Management Office. And lastly, last year, you asked us to take a careful look at steps the state should take to continuation of many of the telehealth waivers that were established as a result of the COVID-19 crisis. The industries pay the MHCC's assessment, but they pay differential shares. Hospitals contribute approximately 39%, payers 29%, nursing homes 16%, and healthcare practitioners 16%. That's reflective of our workload, but it also largely reflects the size of the respective industries. Hospitals are nearly a $19.5 billion industry. Healthcare payers collect over $12 billion in the state on health insurance premiums. The nursing home industry is about a $3.3 billion sector, and if there are more than 110,000 healthcare practitioners in total that are subject to our assessment. We recognize it's always difficult to raise the authority on assessment fees on industries, but we want to point out that we think we're very careful and cautious in the spending of our budget. Until this past year, we had never exceeded the $16 million cap. Our revenue, our appropriation request is $19 million this year. We very strongly encourage you to pass the cap increase. I'm very delighted to thank the committee for its support in the past and hope that we continue to have the support of HGO in the future. And I strongly support a favorable report. Happy to answer questions.
Thank you so much for being with us today. Are there any questions? I see Delegate Collison, followed by Delegate Kurt, and then Delegate Kaiser. Delegate Collison.
There we go. Trying to get the unmute off. Thank you. Thank you, Madam Vice Chair. And first I want to congratulate Delegate Landis on her first bill. I hope that we were appropriately respectful. So good for you.
Thank you.
This is, and I want to thank Mr. Stephan for stepping up. We've asked a lot of MHCC over the last couple of years, and I know that you've absorbed a lot of work. So given that, I want to understand how the cap works, and I'm not the math expert on the committee. Would the percentages of assessments on each of the different elements stay the same, but you would just be allowed to collect more, or will those percentage assessments change in order to get you to the 20 million?
The commission is, through its regulations, conducts a determination every 4 years on our workload, and based on that workload assessment, the proportions of the overall appropriation that each industry would pay for the next 4 years is arrived at. So in the most recent assessment, the hospital industry was judged, they would be accountable for about 39% of our budget, health insurers approximately 26%, and so on. Now we will redo that assessment next year. I would expect that those percentages would change slightly, but given the nature of the work that the commission has been undertaking, I don't expect dramatic changes. So theoretically, what does that mean? Hospitals now contribute approximately in total about $6 million to our assessment. As a result of a cap increase, should you approve that, the maximum we could assess hospitals, assuming the percentage remains the same, is about $7.2 million. And it would be similarly, we would assess the same percentage or approximately the same percentage in the out years moving forward.
Great. Thank you very much. I really appreciate it.
And if you saw the Delegate Landis, all those questions, we usually do that when it's your first time in our testify in our committee. That's why you had like 10 questions. But in reality, there's only Delegate Shalega left. We have all been through it. Delegate Shalega.
Thank you so much. Let me pull the bill back up here. Mr. Stephan, I'm reading the bill, and total fees assessed by the commission may not exceed, and you're striking 60 million, going to 20 million. The fees assessed by the commission shall be used exclusively to cover the actual documented direct costs of fulfilling the statutory regulatory duties of the commission, and also the administrative cost. Do you have an audit you can provide us, or can we actually see the budget? How can you justify increasing that amount?
Thank you, Delegate. So remember, this is a cap. You might think about this, although it's dangerous to say this, the federal budget cap. What we're asking you to do is raise the cap from $16 to $20 million. I can commit to you for 2023 that we will not raise our assessments on the regulated industries to $20 million. In fact, in 2017, the cap was raised to $16 million, but it was not until 2022 that we actually assessed industries up to the 16 million. So we're very prudent about this based on our needs. What has caused us some challenges is the amount of work that we've agreed to take on, the responsibility of supporting the Prescription Drug Affordability Board, which is a temporary commitment, but nonetheless, it represents a financial challenge to us. And so I think when you think about it's raising the cap, but we're not going to assess industries up to $20 million in the next year for sure, and probably 2 years looking forward. I'd be happy to perform, to share with you our most recent audit. It was favorable with one derogatory related to our administration of the Maryland Trauma Physician Services Fund, which they told us to do take some additional work on how we segregated responsibilities in the distribution of those funds. Happy to provide it to the committee.
That'd be nice. And your budget as well. I'm assuming you provide the budget piece to the budget health subcommittee of budget. If we should take a look at that as well.
Absolutely. We will be presenting that budget to the Senate on Monday and on the House on Thursday.
All right. After the presentation, it would be great if we could see that. And one more question, Madam Chair, would be if you can address the unfavorable from leading age, and they make a great point. This pandemic has been really, really tough on our healthcare facilities, especially senior healthcare facilities. And, how can you raise fees on them when they're struggling right now?
So the nursing home industry pays the smallest proportion of MHCC fees next to practitioners. The impact on the industry overall would be, on average, they pay roughly about $12,000. Not average, but I think I'm looking at the median is about $12,000. Should we go up to 20 million, the fees would increase to about $15,000, from 12,000 to 15,000 for a typical nursing home. We understand the challenges that the nursing home industry is facing. However, there are important services we provide to that industry, and we certainly argue that providing information on quality in these facilities, which is a major cost of our work, is an important endeavor for Maryland consumers, as for those that have to face the choice of a long-term care situation and face big concerns about where is it safe for me to go.
Certainly, I have parents in those facilities, and a 25% increase on them seems steep. Thank you.
Thank you. Delegate Landis?
Yes, I simply want to extend gratitude to Chair Pendergrass for the opportunity. Thank you very much.
My pleasure, and her pleasure. Are there any other questions? Seeing none, this concludes, and thank you, Mr. Steffen, for being with us today. This concludes the bill hearing on House Bill 353. And next we have committee members, 2 more left. Hang in there. Delegate Kerr, Human Services, Secretary of Aging, Qualifications. Delegate Kerr, will you be so kind and get started?
Thank you, Madam Chair.
Thank you.
Good afternoon, committee members. I am Delegate Ken Kerr, here today to present House Bill
430, Human Services, Secretary of Aging qualifications. I won't take up much time because I want you to hear from my panel who have greater expertise in this area. But let me begin by providing some demographic information. The Maryland Department of Aging reported in 2015 that 18.35% of Marylanders were over age 60. Now, 22% are age 60 or older, and by 2030, that number is expected to be 25%. Baltimore County is already there with 25% of its population over age 60. Clearly, Maryland's population is getting older, and aging is increasingly becoming a major factor when we discuss healthcare, long-term care costs, mental health services, transportation issues, affordable housing, cost of living, and understaffed senior care facilities. And we don't need a better example than we heard today from Delegate Cullison's bill for home and community-based services. With 66% of those Marylanders over age 60 reporting that they are definitely or probably going to stay right here in Maryland, the next Secretary of Aging will find an increasingly difficult challenge ahead. And now is the time to consider what qualifications we are looking for in this important cabinet position. Thank you for your time and your attention. And I now ask that you call upon my panel.
You're muted yourself, but would you like Ms. Isabella Chaikov to be next, Delegate Kerr?
Can we start with Michelle Douglas, please?
Absolutely. Michelle Douglas.
Thank you, Madam Vice Chair, Madam Chair, and members of the committee. I'm Michelle Douglas, representing the Maryland Association of Area Agencies on Aging, known as M4A. M4A and its 19 associated area agencies on aging represent the front line in Maryland's challenge to meet the complex and varied needs of well over 1 million older adults statewide. M4A strongly supports House Bill 430 due to the growth, maturity, and evolution in the field of aging, and we thank Delegate Kerr for introducing it. The confluence of the surging senior population, the deep expertise and maturation in the field that now exists, and the limited state and federal resources to serve this ever-growing population necessitates a leader with expertise in the field. This bill is forward-looking, and it would not become effective until the next administration. For background, when the Department of Disabilities was created under the Ehrlich administration and passed into law by the General Assembly, it included minimum qualifications for the Secretary of Disabilities. And the two fields, disability and aging, are similarly mature at this point, and they're largely similarly situated. Modeled on what is currently in law for the Secretary of Disabilities, this bill would require the Secretary of Aging to have extensive experience and knowledge of aging laws, regulations, legislation, and programs for the aging, at a minimum hold a bachelor's degree. And specific to aging, it would require commitment to the mission of the Federal Older Americans Act, which is where the majority of the department's funds come from. We are so fortunate in Maryland to have so much expertise in the field of aging all around the state. And we have an opportunity to pull from that existing expert talent and bring into public service a person who's familiar with the important aging practices and trends to help lead Maryland as our senior population continues to grow. M4A urges your support of House Bill 430. Thank you.
Thank you, Michelle, for your testimony today. Next, we have Ms. Isabella Chaikov. Good afternoon.
Good afternoon, Madam Vice Chair, Madam Chair, members of the committee. My name is Izzy Chaikov. I am here to urge your support on House Bill 430. Although I'm no longer employed with Lifespan, I used to be their president for 23 years. And over those 23 years, I had the opportunity to work with the past 4 secretaries of aging in Maryland. And it's been 3 since Sue Ward, really, which was 3 secretaries ago and over 20 years ago, when we've had a person come into that position who came with any experience in senior programming administration. So why do we need this bill today? Well, I can think of a couple of really good reasons off the top of my head. First, the pandemic. The pandemic has been devastating to the state. And of the over 13,000 people who have perished over the past couple of years because of COVID, the majority have been our seniors. And it really exposes how inadequate we are in serving and protecting this group. The precipitating workforce crisis that we're experiencing now because of the pandemic is unprecedented, and it may take years for us to get back to a place where we have the numbers of people that we need qualified to take care of our seniors in the aging population that we have. Another reason is just the waiting lists. We've heard today the waiting lists are embarrassing, and it doesn't matter whether we're talking about community-based services or affordable assisted living or senior housing. The waiting lists are epic. The sheer demographics, which have already been spoken to by the sponsor and by Michelle. So Madam Vice Chair and Madam Chair, members of the committee, we simply must do better by our seniors. I think it's time for us to elevate and prioritize senior care programming and services in this state. And we can start by setting out minimum professional expectations of our future aging services secretary. So I urge you to pass House Bill 430. Thanks.
Thank you so much. And thank you for your work in the state. We appreciate it. Next, we have Ms. Barbara Riva.
Yes, hello. Thank you. Thank you, Chair, Co-Chair, and the committee. I'm here to support House Bill 430. As I indicated, I'm a geriatric social worker with well over 40 years experience in the field of aging. Most of my professional career was spent at the University of Maryland, Baltimore, leading an interprofessional program on education in geriatrics and gerontology. Through that, the program provided interprofessional education for professionals in the field of aging, for caregivers, for long-term care professionals, and most importantly, students in the university system of Maryland who were interested in learning about working with older adults in an interprofessional collaborative way. I'm now retired and serve on the boards of numerous nonprofit organizations in Baltimore City working with low-income older adults. As indicated before, my testimony is also forward-looking and should not be taken necessarily as a reflection about any of the past secretaries of aging. It's based on my decades of experience in working in aging and knowing its complexity. From day one, the secretary must demonstrate leadership and understanding of the myriad social service, health, and mental health issues confronting a diverse population of older adults and their caregivers. The expertise is not and cannot be easily learned on the job. In addition, the secretary should be a colleague and learn how to work collaboratively across department lines to ensure a good system of delivery of care. And that was further emphasized today by many of the people who testified on a number of bills. I think Maryland can be a wonderful example, and I hope we will support this bill. Thank you.
Thank you so much for your testimony today. We appreciate it. Next, we have Ms. Kimberly Burton. Ms. Burton.
Thank you. Thanks to everybody on the committee for the opportunity for me to offer my support for House Bill 430. You have my written testimony. I'm going to speak a little bit off script here. I have 30 years of work in the aging field, and my area of expertise is behavioral health. I'm speaking today as a resident of Baltimore County, where you've already heard our very high number of older adults. And in my testimony, I have a graph showing you the growth of the population. And I give that to you as a visual to assert the intent of my testimony, which is, as we have a growing population of need for services and programs, we need to have growing expertise in the delivery of those. We need to have a Secretary of Department of Aging who has the relevant qualifications for leadership. Again, this is only forward looking because of the demands that we have for this population, which is increasingly diverse. You'll see a reference that I give in my testimony to a October 19th Joint Chairman's report about the development of cognitive health and plans for Maryland's aging population. And you can read in that report that the needs of this population are incredibly complex and serious. And these includes things like addiction and overdose and suicide. This is not the days of treating this population as a homogeneous group are well over. And the diversity of individuals between the ages of 60 and 100, which is a 40-year age span, really necessitates an understanding and level of expertise for how to best deliver programs and services for this group. I urge your favorable report on House Bill 430. Thank you.
Thank you for your work. We appreciate it. Next, we have Ms. Carol Lanehart. Good afternoon. Is she here, Richard?
Yes, I believe so.
Unmute and there I am. Okay, I was afraid that I'd gotten all dressed up for nothing.
No, you look great and we can hear you, which is most important. So good afternoon and you can get started.
Oh, thank you very much. Good
Our
afternoon.
pleasure.
Good afternoon, everyone. My name is Carol Lanehart and I'm here today as the co-chair of the Maryland Senior Citizens Action Network. And I want to talk kind of briefly about how the complexity of aging services have changed over the years of my career. I began my career in 1980 with a master's degree from the University of Maryland Center on Aging in College Park. My testimony today is based on 42 years of subsequent experience. And I've served as the director of the Harford County Office on Aging and a past president of the Maryland Association of Area Agencies on Aging. And over these years, I have seen significant evolution in the complexity of aging services. Early on, the services for seniors were primarily based on a social model that were offered in senior centers where older people would gather and enjoy meals together and participate in activities primarily focused on avoiding loneliness and isolation. But as the years went by, we had more and more seniors beginning to live longer, and the health needs of our elderly began to require the aging network to include a medical model of services and programs to address not only those social needs, but also chronic health needs as well. And these more complex programs, such as senior care and the Medicaid waiver, require leaders to have the education and the experience to develop and administer much more complex programs to give effective solutions. Right now, the elderly citizens in Maryland, their population is increasing dramatically. So it's even more important than ever to choose future leaders of the Maryland Department of Aging who are prepared with both education and experience to effectively manage these new complex programs. And we ask your support of House Bill 430 and appreciate your time and listening today.
Well, thank you for being with us today and we appreciate your time. So are there any questions for House Bill 430? We have first Delegate Kaiser.
Thank you, Madam Chair. My question is for the sponsor. I've met with one of the advocates, so I know that this bill doesn't impact the current Secretary of Aging. But my question is it at all a reflection on the current Secretary of Aging? Because if so, I would not be able to support it.
Delegate, I don't think that that this is a backward-looking bill. I think this is a forward-looking bill, and anticipating that this field is only going to become more complex and more demanding of the next Secretary of Aging. But I don't have any quarrel with the current Secretary.
All right, thank you, my former state senator. Thank you.
Thank you. Delegate Krebs.
Thank you. I was just reading the fiscal note. It talks about now that we have to have the advice and consent of the Senate. And I always was under the impression that's where the vetting took place. Number one, do you know if any of the other cabinet secretaries have these type of specific criteria in their job description before they're hired, number one? And secondly, do you not think it's adequate for the advice and consent of the Senate? I guess we're saying they're not doing a good enough job of consenting, but do you know if there's any other secretaries that have this type of these kind of requirements?
Yeah, thank you, Delegate Krebs. Ms. Douglas did mention that the Secretary of Disability is one of the newer cabinet positions does, and I can't recall right now which position it is, but there's another bill going through the legislature this year that's looking to set minimum qualifications for one of the cabinet secretaries. So it's not without precedent.
Thank you. And I want just one other quick question. In here, one of the things was at minimum hold a bachelor's degree. And I just always question that minimum of a bachelor's degree, who we might be eliminating a 20-year veteran colonel and aging. So why is there something of a minimum of no specific bachelor's requirement?
Usually the thinking in a situation like that is people in positions of leadership in the industry tend to hold degrees. A college degree, it indicates a few things that are really important. The ability to set a goal and achieve it, the ability to overcome obstacles, the ability to use data to make and support decisions. So those are a lot of things that someone who holds a degree has had to prove in order to complete the degree. And it's becoming increasingly a minimum qualification for a professional position.
Thank you.
Madam Vice Chair.
1 second. 1 minute, please. I don't see any other questions or concern. And Michelle, we're only allowed one person can only be asked. Okay. Thank you. Are there any other questions for this bill? Seeing none, this concludes the bill hearing on House Bill 430. Thank you so much for being with us today. We appreciate it. We have our last bill of the day, which is House Bill 275, and this is Delegate Love, and it's titled Environment, PFAS, Chemicals, Prohibitions, and Requirements, also known as the George Walter Taylor Act. Good afternoon, Delegate Love. Will you be so kind and get started?
Thank you, Madam Vice Chair and Madam Chair. Before my 5-minute start, I would like to notice that I am ceding 1 minute to Mrs. Taylor. So I will only be taking 4 minutes.
Sounds wonderful. Our pleasure.
Thank you. So for the record, I'm Delegate Sarah Love, here to present HB 275, which would ban the manufacturing and sale of firefighting foam, food packaging, and rugs and carpets with intentionally added PFAS. So PFAS are toxic chemicals that have adverse effects and are found in Maryland. This bill seeks to stop some of the ways in which PFAS are entering our water and our bodies. As the Vice Chair noted, this bill is named in honor of George Walter Taylor, a firefighter at Patuxent Naval Station. I want to start by letting you know the scope and magnitude of what we are dealing with. Across administrations, from President Trump to President Biden, across states, from California to Florida, Connecticut to Kentucky, Washington to Maine, from the Department of Defense to the EPA to the Maryland Department of Environment, PFAS are a problem that we are all grappling with. So what are PFAS? Basically, PFAS are a group of manufactured chemicals that create a barrier between a surface and grease or oil. So think about your takeout container, and the reason that the grease doesn't land in your lap can often be PFAS, but there are alternatives, so it is not always PFAS. But as this barrier, these chemicals have been used in Teflon, nonstick cookware, firefighting foam, food packaging, rugs and carpets, and much more. And they're known as forever chemicals because they break down very slowly, if at all. PFAS exposure is dangerous. It's been linked to increased risk of cancers, reproductive effects, developmental effects or delays in children, reduced ability of the body's immune system to fight infections, including reduced vaccine response, and other health effects. And so, as I mentioned, we have these chemicals in Maryland. The last few years, the Maryland Department of the Environment has been testing community water systems. And in 75% of the systems tested, systems that furnish water to 70% of Marylanders, 75% have discernible levels of PFAS. The MDE even had to issue an advisory about elevated levels of PFAS in fish. So just to add to this, just this week, an article came out about farmers in Maine whose crops are infected with PFAS. Their water is poisoned, their crops are unsellable. Their toddler drinks this water, they're terrified. So this is a nonpartisan public health matter. It's about stopping poisons at the source. It's about keeping our firefighters safe. It's about keeping Marylanders safe. It's about keeping our farmers, the food they grow, and the food we eat safe. Finally, before I close, I want to take a minute to address some of the opposition. First, the retailers testified in the Senate that if we took their amendments, they would drop their opposition. We did. They didn't. Second, the chemical companies will say that they don't like the definition, that it's too broad and we should narrow it to only a few that they now admit are toxic. So this is the same definition in all of the other states that have similar laws, and you can see the long list of these other states in my written testimony. And second, what these companies are doing is classic. They spent decades and millions of dollars refusing to admit that they knew certain of the chemicals were toxic. And now they're saying, oh yeah, absolutely, those are topics and we should regulate those, but not these. But when you regulate only a few, companies then shift one or two molecules and thus avoid regulation. And experts in the field have pointed this out and shown other ways. So I'll stop now and cede the rest of my time. For the foregoing reasons, I respectfully request a favorable report. Thank you.
All right, thank you so much for your testimony. And who would you like to give your time to?
Mrs. Taylor.
Wonderful, thank you. Mrs. Taylor, good afternoon.
Good afternoon, Madam Chair, and thank you for the opportunity to be able to speak today. My husband, George Walter Taylor, was 46 years old when he died. We were married for almost 20 years. I came from a family heavily involved in the fire rescue service, both career and volunteer, so we were the perfect match. I'm a nurse, so in addition to sharing intense work hours, I share his commitment to helping others. Together, we raised 4 children and spoiled 2 grandchildren, whose ages range from 1 to 20 at the time of his death. Walter spent 31 years of his life in the fire service, starting at the age of 15 and ending the moment he took his last breath. As a career and paid fireman, Walter was a strong advocate in protecting the health and safety of his fellow firefighters. He knew about the risk of exposure to pre-polyfluoroalkyl substances known as PFAS, which he and his colleagues were exposed in some of the firefighting foams that they used, in the air when consumer products like rugs, carpets, and upholstery burned, and even from their gear, which is coated in these chemicals. Walter's lifetime exposure to PFAS was 31 years. His use of AFFF and exposure to combustible materials on the fire ground, all while wearing his turnout gear, resulted in devastating consequences to him and our family. In May 2018, Walter was diagnosed with stage 4 metastatic neuroendocrine cancer. For 2 years, we tried various treatments to decrease the spread of his cancer with no success. Walter died on Monday, Memorial Day, May 25th, 2020, with all of us at his side. His autopsy listed the cause of death as metastatic neuroendocrine cancer related to occupational exposures. Walter is not alone. According to the International Association of Firefighters, cancer is the leading line of duty cause of death for firefighters, with 75% of firefighter deaths from occupational cancers. I can't bring Walter back, but we owe it to him and the families of Walter's fellow firefighters to do everything we can to reduce their exposure to PFAS and other cancer-causing chemicals. Doing so will not only help our firefighters and their families, but all of us. Firefighters like Walter are the canary in the coal mine for these chemicals, which are putting all of the risk on as they make their way into the air we breathe, the water we drink, and the food we eat. Since Walter's passing, his oldest daughter, Miranda, has given birth to our 3rd granddaughter. Our daughter, Kayla, is a paid EMT volunteer firefighter that is getting married this year to a firefighter. Our son, Justin, is a volunteer firefighter aspiring to be a paid firefighter. Our youngest daughter, Mackenzie, celebrated her 10th birthday last week and has dreams of being a firefighter just like Daddy. We know that Walter is always watching over us, but our desire for him to physically be here breaks our hearts on even the happiest of days. Fortunately, we have a chance to help protect Walter's fellow firefighters and Maryland families from ever having to feel the pain, hurt, and loss that my children and I feel every day. The George Walter Taylor Act will stop the use of these dangerous chemicals in rugs and carpets, food packaging, and ensure they switch to safer alternatives for firefighting foam. This bill will also require notification for all firefighting gear that contains PFAS chemicals. I am calling on everyone to support House Bill 275 to protect the lives of our firefighting brothers and sisters so they can continue to protect your life and the lives of Maryland families. Thank you.
Thank you very much for your testimony, Ms. Taylor. And we also are very sorry for your loss, and we thank your family for your husband's service. Thank you. Next, we have Ms. Linda Bourbon. Good afternoon.
Good afternoon. Thank you for having me. I am Scientist Emeritus and former Director of the National Institute of Environmental Health Sciences and the National Toxicology Program. I am also a scholar in residence at Duke, a full adjunct professor at Yale University, University of North Carolina, Chapel Hill, Duke University. I could go on, but I want to briefly go over what the challenge of more than 12,000 PFAS are. That number keeps increasing. Only a year ago, I was saying more than 9,000. My slides that I had prepared are in the bill folder for the committee to review. So we've already basically heard that we're exposed to PFAS through a whole range of different products. I should say there are over 200 different use categories of PFAS, whether it's ski wax or dental floss or water protection information on your hiking boots or protection of stains on your carpets. All organisms, or I should say PFAS impact, can cause impacts not only in all animals in which it's been looked at, but also in people. And essentially all stages of our life from before we're even born to old age can be impacted. And essentially every organ system in our body can be impacted. There are some key research questions. We don't know how to get rid of these forever chemicals that we use. And we need to begin to ask the question, are they essential? PFAS should be regulated as a single class of chemicals because they will all be with us forever. And as we start testing more than PFOA and PFOS, what we find is that they do very similar things and impact our health. At the moment, states are weighing more than 210 bills on toxic forever chemicals in 2022. Thank you.
Thank you very much for your service. We appreciate it. Next, we have Ms. Emily Scar.
Thank you, Madam Chair. My name is Emily Scar. I'm the director of Maryland PIRG, the state public interest group. We're proud to stand today with the firefighters and dozens of public health and environmental groups to support the George Walter Taylor Act to protect our families and firefighters from PFAS exposure. Thanks to Delegate Love for all of her work on this bill and to the committee members who co-sponsored Delegates Bagnall, Hill, and Lewis. And this is bipartisan legislation, which is incredibly important. A few things have changed last year. As you heard from Delegate Love, PFAS contamination is broad in Maryland in our drinking water and has led to a fish consumption advisory from MDE. Last month, Prince George's County also sued chemical manufacturers over PFAS contamination in their waterways. And numerous states have taken action to ban PFAS in firefighting foam, food packaging, and other consumer products. But until you act, PFAS contamination will continue to grow in the state. The bill is based on existing laws throughout the country to align with corporate trends in reducing PFAS use in manufacturing, designed to catch us up with other states in this growing crisis. My testimony has a full list of state actions and what companies are doing. And we are really happy to work with the sponsor and the Retailers Association and MACO to address all their concerns. To be clear, the bill does not ban PFAS in all uses, but it does ban all PFAS in the uses covered by the bill. We need to regulate them as a class as defined in this bill. And your committee is all too familiar with what happens when we don't take on toxic chemicals as a class. We end up in an endless game of whack-a-mole, which is why the International Association of Firefighters and public health experts recommend this approach. Fortunately, the contamination levels in our drinking water are mostly low so far, but they still pose a danger to our health, especially for our children, not to mention the occupational health hazards for firefighters and military families. So let's do our best to get ahead of this problem so we can minimize the harm to health and the environment. We respectfully request a favorable report.
Thank you for your testimony. We appreciate it. Next, we have Mr. Brent Walls. Mr. Walls, good afternoon.
Thank you, Madam Chair. I appreciate the time to give testimony. I apologize for the convenience. I've been out in the field testing water quality in the Upper Potomac. So I just wanted to say that our organization has collected water samples in Antietam Creek up here in the Upper Potomac in Washington County. And the levels that we have seen coming out of wastewater treatment plants, two of them specifically, Hagerstown and Smithsburg, were extremely high. And neither one of these facilities have industrial sources of PFAS. So that means the PFAS is coming from products that people use and then dispose of through the sewer system and then into our treatment plant. So it's important that we really start thinking about banning products that have these PFAS in it. And the point of having the family of PFAS is important because there's been research that shows that even the smaller chains of fluorinated carbons that's in that family of PFAS, once it gets into an environment like a wastewater treatment plant, it reconstitutes and creates those longer strains that are just as toxic and that are in the AFFF foams and in the packaging, food packaging. So it's important that we really treat this as a family. And second of all, I was in the military and I used AFFF on airplanes. And I'm concerned about the blood levels in my system. I'm also concerned about the levels and the exposure that my stepdaughter and her friends who have gone through the fire academy in Washington County, and all the students that have gone through fire academies throughout the state, and their potential future exposure of a chemical that's in AFFF. And they're so excited to go out and put out fires and use the equipment and use the foam and everything else. They're just not aware of the kind of exposure and problems that could be to their health as they get older. I urge a favorable report. Thank you.
Thank you for your service and for being with us today. And just for the record, Mr. Wall is in a car, but is fully stopped and he's not driving.
Exactly.
Yes. Next, we have Mr. Jeffrey Buttle. Good afternoon.
Good afternoon, Madam Vice Chair. Jeff Buttle, President of the Professional Firefighters of Maryland, representing over 12,000 active and retired firefighters and paramedics across the state of Maryland. Here today to testify in support of House Bill 275 that is named after our fallen brother, firefighter George Walter Taylor. The issue of concern with firefighters in this legislation is over the course of a 20 to 30 year career, sometimes even more, it is a slow accumulation of PFAS chemicals in the systems of our firefighters that in the long term lead to them coming down with cancer. Cancer is the leading cause of firefighter line of duty deaths. And while this General Assembly has been extremely supportive of passing legislation and having signed into law or enacted into law protections for firefighters that come down with cancer, our goal with this legislation is to limit the exposure to these toxic chemicals that are forever chemicals that once they get absorbed into your body, they are there forever. We want to limit the exposures that our firefighters are incurring over the course of a very long career. And we not only owe that to our current firefighters on the job, we owe it to our next generation of firefighters to ensure that they are not exposed to these toxic chemicals that ultimately, in many of our firefighters, result in cancer. We are here in support of the bill. We look forward to working with the committee. And I'll just also note by reference in my written testimony, I provided a document in response to some of the opposition. I don't have a lot of time to go over it now, but it is in my written testimony, and I'm happy to work with the committee moving forward on this piece of legislation. So thank you, and I urge a favorable report.
And thank you for your service. We really appreciate it. And this actually concludes the testimony on the favorable panel. There are many letters of support that the committee has. Now we're going to go on to the unfavorable panel, which we're going to start with Mr. Michael Rochford. Good afternoon, sir.
Good afternoon, Madam Vice Chairman and members of the committee. Thanks for the opportunity to speak with you this afternoon. I'm Mike Rochford. I'm an associate with W.L. Gore and Associates, a privately held company and a Maryland manufacturer since 1973. Gore employs approximately 2,900 associates in Cecil County. We make a number of technologically advanced products of high societal value. I'm here this afternoon to speak in opposition to House Bill 275. While Gore does not make firefighting foam, rugs and carpeting, or food packaging, we do use fluoropolymers, a type of PFAS, which are included in the 4 to now 12,000 substances defined as PFAS by this legislation. But not all PFAS are the same. We believe that the definition of PFAS is overly broad, and we're concerned it could lead to unintended restriction of fluoropolymer, which Gore uses to make products including implantable medical devices approved by the FDA, Gore-Tex membrane, and products used by the pharmaceutical industry to make COVID-19 RNA vaccines. Again, our principal concern with the legislation is with the definition of PFAS, and that it includes fluoropolymers, which are highly stable, too large to be bioavailable, and do not have the potential to become widespread in the environment. We would offer as an alternative an amendment that would better define PFAS as a group of man-made, non-polymeric substances that contain at least 2 fluorinated carbon atoms, excluding gases and volatile liquids. PFAS chemicals would include PFOA and PFOS. We think that is a more tailored approach. We'd also suggest that the state's interests would be better served by taking a regulatory programmatic approach rather than just affecting legislative ban of products. Thanks for the opportunity to testify today.
Thank you for being with us. We appreciate it. Next, and we're going to have questions after both panel have presented. Next, we have Mr. Mitch Hubbard.
Thank you, Madam Chair. My name is Mitch Hubert, and I hold degrees in both biology and chemistry and have been working in the firefighting foam industry for more than 40 years, both as a formulation chemist and as a firefighter. I'm here today representing the Firefighting Foam Coalition to urge you to reconsider House Bill 275. Our coalition is made up of foam manufacturers from throughout the world who fully support efforts to reduce the use of PFAS foams and are working feverishly to develop and improve non-fluorinated alternatives. All of the foam manufacturers within the FFFC make fluorine-free foams and fully support a timely transition to these products wherever possible. In fact, we believe that most municipal fire services could transition today, but that is not the case with many industrial fire services. Unfortunately, there are still fire scenarios and industry segments where the current technology utilized in fluorine-free foams falls short of providing the type of performance that can assure that large catastrophic fires can be successfully fought and extinguished, and which provide a measure of safety for firefighters and other first responders. As such, the proposed legislation could hamper and possibly prevent firefighting efforts in these high hazard applications. While we continue to make advances in fluorine-free foam technology, we are still not at the point where those products can be considered as drop-in replacements. This is substantiated by a recent study conducted by the National Fire Protection Association Research Foundation in a rather extensive testing program that looked at the effectiveness of fluorine-free foams. Their conclusion, which is published and can be made available, is that there is more work to do with these products in some fire scenarios. We urge you to reconsider this bill and allow the continued use and sale of fluorinated firefighting foams for some very specific exemptions. And these would include refineries, chemical facilities, bulk fuel loading terminals, and fixed foam suppression systems. Thank you.
Thank you for your testimony. Next, we have Sean Swearingen. And I'm sorry if I did not pronounce your name like Hubert. I apologize, but go ahead.
That's all right, Madam Chair, Vice Chair, really appreciate it. Great opportunity to testify on HB 275 today. My name is Sean Swearingen, and I'm the Director for the Alliance for Telemer Chemistry Stewardship. While there's common ground on the legislation and we agree to some of the principles, we oppose the bill as presently written. As previously mentioned, the broad definition of PFAS contained in the bill includes hundreds, if not thousands, of different chemistries. The definition needs to use clear and concise language while focusing on the specific chemistries of concern. There are others here to speak to this, such as Mitch before me. HB 275 rewrites fluorinated firefighting foam, also known as AFFF bill, that was passed 2 sessions ago and went into effect at the end of 2020. That legislation created many protections, including standards for treatment and containment as well as bans on testing and training, which effectively eliminated 90% of the use of AFFF. As previously mentioned, it is the most effective suppressant for flammable liquid fires occurring in many military, industrial, and aviation situations. While their fluorine-free foams are available and can provide an alternative to AFFF, in some applications, they do not meet the necessary performance requirements for a significant liquid fire event. Another critical point of 275 is its language also seeks to undertake further regulation of food packaging materials when industry is already phasing out use of PFAS in food packaging by the end of 2023. And the current supply chain challenges, the accelerated effective date may further reduce the availability of certain food packaging used by restaurants and facilities within Maryland. As ATCS, we recommend a clear definition of PFAS while underlining the different class of chemistries within it. Restoring the bipartisan AFFF foam regulations put into place 2 sessions ago, while allowing use in emergency Class B fire situations, allow the destruction of AFFF using pollution control measures, and aligning the food packaging sunset timeline with FDA to end December 31st, 2023. Thank you, and look forward to working with the sponsoring committee.
Thank you for your testimony today. Next, we have Ms. Kaylee Lackler. Good afternoon.
Good afternoon, honorable members of the committee. For the record, Kaylee Locklear here on behalf of the Maryland Retailers Association in opposition to this bill. And I do want to make it clear that our opposition has nothing to do with the firefighting foam. That's the first topic addressed in the legislation. We are so grateful to our fire heroes in our communities. To the sponsors' comments, our organization in good faith has been working on amendments that we truly hoped would essentially remove distributors and retailers from this bill. We did offer a handful of these amendments on the Senate side. We were working with the House sponsor, but then when our legislative committee met on Monday, we found they still do not go far enough to address our issues, which I'd like to explain. First, on page 7, the definition of manufacturer includes any person that sells a package, which we obviously do. On the private label side of things, they end up outsourcing packaging and then assembling food items with it, and they'd be captured under this definition, which is a problem. The second is the bill is problematic as you move down the supply chain as distributors and sellers who do not fall under the manufacturer definition just aren't manufacturers, and they don't know what is in an item as just intermediaries in the supply chain. Number 3, we're not clear if rugs that are broadloom carpet would be captured under this too, which in case we have private label members that would be impacted. Number 4, the broad definition of PFAS, even for companies that are larger in our membership that have used labs to test for products shared, that they're going to have problems testing for the hundreds of chemistries that fall under this. And then finally, the compliance certificates for materials used in rugs and food packaging. That's a problem if you don't know what's in the product either. We look forward to working with the committee and appreciate your time today. Thank you.
Thank you very much. We have Mr. Robert Simon.
All right. Thank you, Madam Chair and members of the committee. Thank you for the opportunity to testify in HB 275 related to PFAS. My name is Robert Simon, and I'm testifying today on behalf of the American Chemistry Council. Overall, the chemical industry supports the strong regulation of chemicals, including PFAS chemicals, to help protect human health and the environment. We've worked with the legislature in Maryland to enact legislation on some of these issues over the last several years. However, we respectfully oppose the current version of HB 275. In its current form, this legislation is overly broad and will have unintended consequences. I'd like to emphasize just 3 key points today. Despite some of what you've heard today, PFAS are not all the same, and it's not appropriate to group them all together. These include a broad range of products, solids, gases, liquids with very different properties and very different uses. Everything from medical equipment to electronics to semiconductors to supporting alternative energy technologies like solar. So it's just not appropriate to group them all together and treat them the same. And just as by way of example, take another broad class of chemistry like hydrocarbons, which also include solids, gases, and liquids. We clearly recognize and would never treat propane gas, alcoholic beverages, and plastic jugs as the same, but those are all hydrocarbons. So we think there's an opportunity and a need to differentiate within this broad family of chemistry. Second point I just want to emphasize is that we think the bill can be further focused to focus on Maryland priorities. Let's focus on those chemistries that have the potential to get into the environment and that are used in the applications of concern, and happy to work with the committee to further refine that. And then lastly, as we look at specific applications, we want to make sure that we ensure overall public safety and product availability. So right now, HB 275 would restrict a number of key product areas. And as noted earlier from some others, this includes some things where there may not be alternatives available. So as the committee works on this, we would encourage you to, one, look at those things where there is a equivalent available alternative. Second, that there are appropriate transition periods for those uses, and that any proposed restrictions align with other state and federal actions so that we avoid creating a patchwork of conflicting and inconsistent state and federal regulations. So appreciate the time today. We would encourage the committee to work with stakeholders to consider targeted amendments that would ensure the strong regulation of PFAS chemicals for the issues that we know are important for Maryland, while also ensuring overall public safety and avoiding some of these unintended consequences. Thank you.
Thank you for your testimony today. So we're going to first ask questions of the primary sponsor, the favorable panel. We're going to take those questions first. So I have first Delegate Hill, followed by Delegate Johnson for the favorable panel.
Thank you, Madam Chair, and Delegate, thank you so much for this bill. It sounds like, and I'm sure you've always been open to having discussions with folks on either side to kind of get a better product. My specific question is, when we've done some of these bills before and we ban further sale, we often put some language that allows for, stuff that's already been purchased, that's in stock, et cetera, to be sold. And I'm wondering, do you have any objection if, as this bill moves through committee, to not an out-and-out ban, but rather it can't be sold after, you can get rid of whatever stock you have, but you just can't acquire more stock to sell in the state?
Sure, I certainly would be open to that conversation. One of the amendments that we have been talking about is extending the timeline. The other states that have done this have given a 2-year window. So we certainly would be open to a 2-year window, because that would allow the folks who have the food packaging and rugs and carpets to go through their system. Couple of things. One, and then two, a lot of private industry is already moving in this direction. I mean, McDonald's and Cava and Trader Joe's, they're no longer selling this stuff. Home Depot, Lowe's. So there's not as much inventory as you might think there is. Second, one of the things that we are working with is we're working with MDE on a buyback program, because we don't want the firefighters to continue to use this stuff. And notwithstanding what some of the other folks have said, I mean, there are at least 7 other states that have banned this. There are 4 international airports that have banned this foam. So there are alternatives out there. National Foam is no longer selling PFAS-laden foam into Maryland. So there are alternatives out there. So we're working on a buyback program so that our firefighters don't have to continue to use this stuff, so that we can get rid of the stuff and ban it straight out.
Okay, and as a follow-up, so the interest in a different, tighter definition, because it sounds like even your answer, it's really the foam products and some of the things that can burn. You're open to that discussion about a definition that may potentially exclude? You'd have to be convinced that they are positive PFAS containing objects. How were you on that?
So I do not think that narrowing a definition to specific things that the industry names is the right thing that Maryland should do. Like I said, there are multiple other states that have this same definition when they ban these products. And we have seen the companies when certain products are banned or certain PFAS are banned, you'll notice in my written testimony, there's conversation, the EPA has regulated long chain PFAS in carpets. So they change 1 or 2 molecules and then it is no longer regulated. And then you've got some that are looking at the health hazards of long chain PFAS in food packaging, some that are looking at short chain PFAS in food packaging. So we really do need to regulate these as a full class.
Thank you. Delegate Johnson, did you have a question?
My question was answered, Madam Chairman. Thank you.
My pleasure. Next, we have Delegate Lewis, followed by Delegate Riley.
Thank you, Madam Chair. Thank you to the good delegate for bringing this bill. I have a question about regulation. I think this would be for Dr. Birnbaum. In my limited experience, we typically impose regulations on chemicals that exist. Is it an overreach to talk about restricting or regulating chemicals that haven't been invented yet? As has been mentioned already, it only takes a change in a single molecule of a chemical to alter it beyond the reach of a regulation for an existing product. How should we think about this?
I think we need to understand that PFAS, by definition, are forever chemicals. The carbon-fluorine bond is extremely difficult to break. It is not broken in nature. And so far, no one has been very successful at trying to break down any kind of quantity of PFAS. You can break them down sometimes on a lab bench, but not otherwise. As we move from one PFAS to another, and there are really, I said there are over 12,000 on EPA's list. Many of those are not intentionally produced. Some of them are the products of the production of the PFAS that is sold. Some of them occur during the life cycle of the materials. Polymers are responsible for almost 80% of all the PFAS that get into our bodies that are out there. So I think we need to realize that. But the question that you were asking, Delegate Lewis, is what do we do? How do we know about the next one? And what I'm saying is that every one that gets made, not everyone is going to cause exactly the same thing, but they are all extremely persistent in our environment. And they all move around the world. They not only are present near where they're being produced or used, but we now know that, for example,
Doctor, your audio is a little breaking up. I'm sorry, Madam Chair.
Yeah, 1 second, Delegate Lewis. I don't know if you're too close to the microphone, perhaps.
No, I'm sorry, I'm doing the best I can. Is that better?
That's better.
That's better.
Okay.
Just finish that last bit. You were saying that they persist in nature, they don't break down.
They are extremely persistent. They don't break down in nature and they travel all over the world. So we have the use of PFAS has not only contaminated every single one of us here in the United States, but all around the world, especially our indigenous peoples of the far north and our marine mammals and our polar bears and that kind of thing at very high levels.
Thank you. Thank you, Madam Chair.
My pleasure. Thank you, Delegate Lewis. We have Delegate Riley.
Thank you, Madam Chair. Yes, and I guess my question would be for Delegate Love, because I've heard you say several times that you don't agree with some of the amendments that were in the Senate. I don't know what they all are. I don't have a copy of those, and that you didn't feel like you needed a tighten up the definition of PFAS. I don't know if you've seen the letter, the written testimony from the Cecil County Chamber of Commerce, but it kind of goes into a little bit about the difference between, or a different type, I guess, of PFAS. Again, I'm not a chemist, but I've spoken to several people and they've given me like the 101 maybe definition of this PFAS. But anyway, they're talking about something, I guess, a product or a different type of PFAS, which is PTFE. And I believe one of the other folks had talked about that. If you look into their letter, we're not talking about the carpets and the firefighter foam and all of that in the food containers. And I know you were specific in not wanting to identify them a little better, but I don't know if you saw this, but what about this one? Because if the definition remains the same, that's in the current bill and it's in its current posture, you're going to possibly eliminate implantable medical devices, waterproof and breathable membranes, pharmaceutical products in the industry. And even Mr. Radcliffe from the WL Gore in his testimony said even with COVID-19. So that's completely, this is medical. So, and what you're talking about is a different area. So don't you see how by not, giving a better definition of PFAS could possibly have, unintended consequences on these medical products and what is made from one of our large, manufacturers in Cecil County?
Delegate Riley, thank you so much for that question. I'm actually very, very glad that you asked that question because it gets to a really important point. This bill isn't banning those things, and those things can't be banned until this committee gets a bill and acts on them, which this committee is not going to do. This bill is very narrowly drafted to firefighting foam, food packaging, and rugs and carpets. And if this committee is so inclined, you can insert in the definition for purposes of this section only, the definition applies to, because it is nobody's intent to ban those other things. And that couldn't happen without this committee's blessing, which I highly doubt would happen.
Okay, Madam Chair, follow up?
Sure.
Then I definitely will be looking at, possibly if this goes to subcommittee to putting an amendment on that to kind of define so that these medical products and what is made at WL Gore would not be banned under this bill.
Certainly a qualifier of, for purposes of this section only. Yes, absolutely, because that's what we're looking at. We don't want to ban medical equipment at all. And many of the other things that you mentioned, that's not what this bill is about.
Okay, thank you very much. Thank you, Madam Chair.
Certainly.
My pleasure. Are there any other questions for this favorable panel? Seeing none, we're now going to go to the unfavorable panel. Are there any questions for the unfavorable panel? I have Delegate Shalega.
Thank you, Madam Chair.
My pleasure.
I have a question for Mike from Gore, and I want to thank you for being a great Maryland company and being based right in the corridor near me. If this bill passes as it is, what would it mean for your company?
If the bill passes, in all honesty, I can't tell you there would be an immediate impact, but what we would be concerned about is the precedential and value, and also the slippery slope. That again, the definition is overly broad. It may not be the intent of this committee as currently composed to catch our products, but that doesn't say what couldn't happen with future committees. And so I guess our argument would be Maryland should get the definition right in the beginning and be focused on those PFAS that are considered as to be problematic.
All right, thank you. And then Mike Hubert or Hubbard, if this bill passes, would the safety of firefighters and other people be in danger? What does this mean for the health and safety of firefighters and others if this bill were to pass?
Thank you for asking the question. And it's important to make a distinction between the municipal firefighters that we've heard testify in favor of it and the industrial firefighters because they face different fire scenarios. And really all we as the firefighting foam industry are asking for is a little bit extra time. We are making progress in fluorine-free foams. Company that I've worked for years and years and years started this way back in 2000, working on new formulas. And unfortunately, in some of those fire scenarios, the fluorine-free foams that we produce today throughout the industry would fall short because there's way too much fuel pickup. And so if you have a fuel and depth fire, like a large fuel storage tank, or a process area or a dike area, the firefighting foams that exist today that are fluorinated, we know can put those out. To date, there's not a single fluorine-free firefighting foam that's ever been used successfully against those types of applications. And so we're only concerned that we get a little bit more time to help refine the products. And as I said, we've been working on it for a long time. We're way further ahead than we were back in 2002 when it was first started. So we would just ask for those exemptions for the industrial firefighters where the product performance is not up to what we would think is necessary to be able to extinguish that fire and save their lives in trying to attempt that fire.
Great, thank you so much.
Thank you, Delegate. We have Delegate Lewis, followed by Delegate Bagnall.
Thank you, Madam Chair. Thank you to this panel for enriching the conversation and helping us see all the different sides. This question is for Mr. Hubert. Thank you for describing the work that's been done to develop other fire extinguishing foams. And if I recall, you mentioned that work has been carried out for about 20 years to identify effective alternative foams, if I heard you right. Is that so? 20 years of research and development. And I'm curious, my question is two parts. First, what was used to extinguish industrial fires before PFAS foams were available?
That goes back pretty far. That goes way back to the 60s. And it was a foam that was called regular protein foam. But unfortunately, that whole industry, the hydrocarbon processing industry, has changed during that time frame. The size of fuel storage tanks has gotten much larger, and the distance between fuel storage tanks has gotten much smaller. And so we do have fire scenarios that have actually existed where a single fuel storage tank catches on fire and would move to the next tank because it was simply not extinguished quickly enough. And so it's part the way fuels are handled and processed today, and it's part the way the firefighting techniques have evolved over the years. Today's methodology uses really high flow monitors that projects the foam up and over and into the top of a tank. Some of these tanks are 60 feet high, and you're looking at flow rates of 5,000 or 6,000 or 7,000 gallons per minute impacting that fuel. It impacts with such momentum that foam actually projects below the fuel surface and floats back up. And with fluorinated foams, they have the ability to shed fuels. That's why they're used in food processing to protect the oils and greases from transporting through the container. And so all of the non-fluorinated foams that exist today do not have that fuel shedding characteristic. And so we're working at different application methodologies. We're looking at ways to apply the foam much more gently to the fuel surface so that it doesn't plunge below the fuel surface. So very specific situations where we still believe that the fluorinated foams need to exist. And we think that the majority of firefighters can transition over to fluorine-free foams today if they wanted to.
And thank you, sir. The second part of my question, if I may, Madam Chair. So you touched on the history of fire extinguishing for these industrial fires. You mentioned that this has been a 20-year timeline of research and development for alternatives to PFAS foams. We've observed in the last couple of years the example of banning styrofoam containers in Maryland, and the concern from the manufacturing advocates was that banning styrofoam packaging would destroy the industry. They couldn't adapt quickly enough. There'd be no alternatives that'd be affordable, that this sort of catastrophic disaster would unfold as styrofoam containers were banned. But what we've seen is that within just a couple of years, miraculously, alternative to those products have emerged. And I'm just wondering if the pressure of tighter regulation might stimulate a quicker development of alternative. 20 years is a long time in chemistry. I'm wondering what you think about that.
Well, certainly we're much closer than we were 20 years ago. And 20 years ago, there wasn't much pressure on firefighting foam manufacturers to get out of the industry. The pressure that we saw 20 years ago was very specific toward a fluorosurfactant called PFOS, perfluorooctane sulfonate, that was utilized in a brand called Light Water. There were alternative brands that were available. And so the efforts to produce fluorine-free foam have ramped up substantially over about the last 5 years or so, as we've seen the pressures, and the pressures are good, and the pressures are correct. But unfortunately, we don't have the silver bullet that allows us to say, any hydrocarbon fuel fire, you can use these fluorine-free foams exactly the same way. You just simply can't, because of that difference of not being able to shed the fuel.
Sure. Thank you, Madam Chair.
My pleasure. Delegate Bagno, followed by Delegate Rosenberg.
Thank you, Madam Chair. And Mr. Hubert, this question is for you, following on, I think the last two questions. So you've said you need more time, but what does that look like? I know in your written testimony, you talked about another locality that was doing 5 years. Are you looking at 1 year, 2 years, 5 years? And what would you need? What would the industry need to be able to expedite that timeline to effectively?
Thank you for the question. I don't know the exact timeline. In my written testimony, we point out that the European Union and New Zealand have proposed a 5-year transition period. And as I said, if you look back 5 years ago, where we were to where we are now, we're substantially better. And so we are hoping as an industry that that 5-year period will get us over the hump on either ways to make that foam shed the fuel better, or different ways to apply that foam to the fuel surfaces on these fuel in-depth fires. So a 5-year transition period for those very specific hazards that we pointed out, we feel at this point are reasonable, and that we could get there in that time frame. The other thing that can happen is that we do know that the non-fluorinated foams have to be applied at a higher application rate. And when you're dealing with a relatively small fire or a spill fire, having a higher application rate isn't a big deal. But when you're dealing with these large fuel storage tanks that I was talking about, and you have to go from 5,000 gallons per minute application rate to 10,000 gallons per minute application rate, that's a huge difference. And many of the refineries throughout the United States have a hard time getting enough water pumping capacity. And all of a sudden, if they have to double it, they're not going to be able to do it. And so those are some of the background issues on why we're asking for a little more time and very, very, very specific exemptions.
And Madam Chair, if I could have a follow-up. So given more time, would the industry still be able to adhere to the other confines, ensuring that it isn't leaking into the water system, ensuring it isn't leaking into the food system? What are the guardrails that you could put around the industry, and what is the potential rate of exposure with a 5-year timeline?
Is that a question to me or to the?
To you, Mr. Hubert.
Oh, I'm sorry.
You're the expert in this particular field.
I'm sorry. Well, keep in mind that firefighting foam is certainly one of the major contributors to the PFAS that we're finding in groundwater and in drinking water. But also keep in mind that the vast majority of that got into the groundwater and ultimately to our drinking water because the rules and the laws required that people train with firefighting foam and that they train with the exact firefighting foam that they were going to use. One of the things that the firefighting foam industry has definitely supported and has kind of backfilled is that we tell people don't train and don't test with fluorinated firefighting foams. And we've gone ahead and made training foams that people can use that don't contain PFAS. And so if you look at the amount of PFAS that got into the environment from firefighting foam, the vast majority of it, probably 90% of it, got into the environment through testing and training and not through actual live firefighting. And so that's why we said simply banning it for testing and training will go a long ways towards accomplishing the goal of reducing PFAS entering the environment from firefighting foams.
Thank you. Thank you, Madam Chair.
My pleasure. Delegate Rosenberg.
Thank you, Madam Chair. If we're not past that time, can I ask the sponsor what her position is on what we've just been talking about? That is a delay of a certain year and a specification. But more broadly, I would ask, is there language that another state or another country has adopted that is acceptable to both sides?
Madam Chair, may I?
Sure, Delegate Love.
Thank you. Thank you, Delegate Rosenberg. As I mentioned, with respect to the food packaging, and rugs and carpets, they've had a 2-year window. I would have to go back and look at the legislation for the, I believe it's 9 other states that have banned firefighting foam, this AFFF, as well as the international airports at Australia, Dubai, London, and Paris that have all banned this. Well, they banned it years ago. But I think one of the things I would like to put out there is that any increased timeline is going to continue to expose our firefighters, whether it is, burning of rugs and carpets or this foam, to, more and more of these toxic chemicals. So I am certainly willing to look at the other legislation in the other states, and if I can find it, the other countries. But I just ask that we keep their health in mind.
Thank you.
Thank you.
Thank you. I have a question from Delegate Shalega.
Thank you for another bite at the apple here. I did want to point out to Mr. Hubert, is it Hubert or Hubbard?
Hubert.
Hubert, that we've talked about this PFAS before. This similar bill has been in front of our committee, and we passed a fire foam bill not allowing it in training a few years ago. So good suggestion. We took it under advisement a few years ago.
Yeah.
And for Kaylee Locklear, if you're still on the call, Delegate Robin Lewis mentioned styrofoam. And I might recall that didn't Dart Industries move out of Maryland after we banned styrofoam, and maybe they went to Delaware?
I think they went north, actually.
Yeah, I think they went to Delaware. So I think, would you say, Kaylee Locklear, that these bans do actually impact businesses in a real way?
Thank you.
Thank you.
Any other questions for this bill? Okay, seeing none, this will conclude the bill hearing on House Bill 275. It would also conclude the work of the committee today. So I hope you have a wonderful, blessed evening. Thank you for being with us.